Right. So it's Edaic 2 preparation tips. Let's start with the time scale, guys. What kind of time scale you need? Everybody's has different circumstances. Some of you are very quick with revision, and you've been with the books recently, so it may not take you more time, maybe 2 to 3 months. But this was what I said probably last year and well earlier this year and last year. But the standard of EDAC exam is getting higher and higher, and I would suggest give yourself at least 4 to 6 months. 6 months to be ideal to not feel pressured. And yeah, that will put you in a right sort of situation on the day of the exam. What are the books that most people read? Masterpast, podcast. These are the more common books that most people read. Emma Plunkett is an excellent book for going through the graphs, diagrams, different sort of visuals that you need to use, visual aids that you need to use in the exam. So this is also a must-have book to prepare yourself, not just for reading, but to practice those diagrams almost on a daily basis. In terms of reference books, we have the Oxford Handbook, the good old Oxford Handbook of Anesthesia, which is always a good book for clinical questions. Uh, Sue and Hill is the pharmacology book. I would have considered this to be the main book for pharmacology, but it's a little bit elaborate. Some people may not find this to be that find this to be quite extensive. But if you're looking to sit exams beyond EDAC, if you're looking to sit FRCA, FCI, I would suggest that you start this book at this point rather than later. It's not a big book. It's a very easily achievable book. So that's a good pharmacology reference. Simon Bricker is a big name in anesthesia viva. He has several books for vivas, for other formats of the exam. But the viva book is a very, very good book. And I found it very helpful in my preparation, as well as the feedbacks I've had from candidates who've sat the exam. They found that a lot of questions were almost repeated straight away from this book in the same format. There are some other books, Oxford Specialty of Anesthesia, Oxford Specialty of Advanced Anesthesia. These are the other two books, slightly more advanced. If you have 6 months and you can really put in a lot of effort, then they are the books that will comprehensively cover the subject.
Good idea.
Okay, so what should be the preparation strategy? I've seen this recurrent times that people are very reluctant to start vivas. They feel that preparation involves just knowledge. So remember, there are two things in your preparation. Knowledge is one part, which plays half, sometimes less than half of the role in you passing the exam. Very, very knowledgeable people have often failed the exam. The reason being, there is something else in this exam which is beyond your knowledge. That is your viva skills. And you have to take into consideration that you start developing your viva skills fairly early on in the can I ask you
देखा
guys
था
to
कोई और idea?
so you can develop your viva skills fairly early on in your preparation strategy. I would say from day one, start building your viva strategies. Don't leave it too long, otherwise the gap between your knowledge and your viva skill just widens, and you find yourself more and more reluctant to start doing the viva practice. So we have something which we'll discuss a little bit later on, called as topic-based vivas, which will help you simultaneously while you're doing your preparation to do the viva practice as you go along. So that is something important that I would say that don't leave vivas for very long. And as the old theory is, learn the game that you have to play on the day. If you were to play MCQ on the day, you have to do MCQ practice. Since this is viva, you need to do extensive viva practice. So that is very, very important. We had a quick survey, I think last year it was, that what contributes to your result, to the attendees of a similar masterclass, and put down 4 reasons. You could think of another reason as well, but lack of revision time, lack of viva practice time, poor access to appropriate study material, communications issues due to examiner's accent, technical reasons, IT reasons. So what would be the biggest contribution in the result? And you'd be surprised to see that 70% of the people mentioned, 70% people mentioned lack of revision time. And then subsequently 17% people said lack of viva practice, poor access to poor access was 9%, and communication issues due to accent 4%. So revision time, people think that is a big contribution. That's a fallacy. If you can take for the whole year for revision, it's the lack of Viva practice that is the biggest contributor to your results. So we will stop this session, this presentation here, and I will just share with you a few other things that I just need to make sure you guys are aware of, and then we will crack on with the Vivas. So as I mentioned to you about these topic-based Vivas. So these Vivas will start pretty much in the 3rd or 4th weekend of January. And they follow a special format. So we have bashed all the things together, like 1 week, there'll be a pre-designated topic for that week. For example, if you have renal system that you have to prepare, it's not just renal physiology, but it's everything related to renal system that you have to come prepared with. Physiopharmacology, anatomy, physics related to it, and clinical applications of that. And on Saturday morning, you will go through all the topic-based Viva on renal system. And likewise, you will follow all the different aspects, pediatric and elderly, all the basic sciences and clinical related to that, obstetrics, intensive care, general anesthesia and pain. This is a big topic. Understandably, we could run this over 2 weekends, but we'll see how it goes. So it's a 10 weeks program. And in 10 weeks, you will cover all these things. Most important topics, cardiovascular and respiratory. They'll follow a bit later on. Central nervous system and neuromuscular system, endocrine, metabolism, so forth. So this will be placed like this. So for example, you start somewhere in January here with renal system. So if you start here from 4th of January, just giving you an idea, that if you start from 4th of, if you start from 4th of January, take it all the way 4th, 11th, 18th, and it ends on 8th of March, right? Now, if you are someone who couldn't start on 4th of January, you could start later on. You could start, let's say, on 1st of February. 1st of February, you start with general anesthesia. And this is a rolling sort of schedule where once we finished renal system, we will start with that again. Once you start the whole first 10 set of topics, we will start again from 15th of March again. So if you started later on, you could complete it later on in the schedule. And the idea is that you get 10 weeks of solid preparation of these topics. 10 weeks is still a very, very sort of less time, to be honest. It's only almost 2.5 months, and that's still not enough. But we have tried to squeeze this for 2.5 months preparation because sometimes you sort of burn out with preparation. So these 10 weeks are the most intensive weeks of your preparation. Please mute yourself. So these 10 weeks are going to be the most intensive weeks of your preparation, and you have to. Sorry. So we have to ensure that you attend these 10 weeks much closer to your exam. Like the 10th week should finish almost 1 or 2 weeks before your exam, so you're able to do your own revision in those 2 weeks. So that's something I would like to make you aware of. So these are topic-based Vivas, which we have introduced for you guys from January onwards, and you can get more information about this from our admin, Mr. Jitesh. Okay, let's start with the most important part of the session now, which is the topic-based, which is the scenarios. I would like some volunteers to come forward. If someone can please volunteer to come up for this first Viva. Now, this is not this is a teaching kind of a session, so I will just take you through a bit of exam scenario, how it goes through. So I'm not going to be grilling any of you guys. It's just a run through of what to expect in the exam. So what I would like you guys, because there will be Vivas coming along. If you want to have a Viva, please put your name if you want to volunteer. The recording of the session will be available. I'm just
Good morning, Dr. Danish. Can you hear me?
I can hear you very, not very clearly. A little bit. If you increase your audio.
Okay.
Your volume.
Now am I audible?
You're certainly audible. Still low, but I can certainly hear you. Can the rest of you guys hear her?
Yes.
Perfect. And can you guys hear me clearly throughout, or was my volume low?
No, clearly we can hear.
Okay, fantastic. Yes, Dr. Purva, you're saying something?
Yeah, I would like to volunteer, though I'm not prepared. But as you gave so many suggestions, I think I will volunteer.
Perfect. That's the spirit. This is not some a Viva which is checking your knowledge. This is a taster session, as I said, and you will all enrich yourself by volunteering, by listening. There are so many videos available. It's the same thing. But come forward and volunteer as much as possible. Fantastic. So, Dr. Purva, I'll call you Purva. It's if that's okay, because we
Absolutely
like.
fine. It's absolutely fine, sir.
Okay. And you equally, you guys can call me Danish. It's not a we're not here in a formal setup. Okay. So I will give 1 minute of. Let's start with this scenario here.
मोबाइल आया मिलेगा नहीं
Okay, so the scenario is here. Take a minute to read it, and take a minute to absorb and to make your own notes on it. This is how the scenario is presented to you in the exam, not necessarily with a blood gas or a diagram, but this will be a standard starting scenario. You are given a minute to chart your Viva. This is the time you will make your game strategy. This is the time you are warming up for an actual showdown. And you have to, at this point, you have to spread your field. I'll give you an example here. This is, at this point, you don't have to focus on one particular thing and run in a straight line. This is not a Usain Bolt moment where you have to run quickly and achieve the finishing line. This is a moment where you will be tackled, and you have to have a good awareness of the field. It's like a football field or a rugby field where you know where everybody else is standing, what positions are there. How are you going to navigate your Viva through and through? The more assessment you have of this, the topics that can be asked, the better you will face the situation. So give yourself 1 minute from now, all of you, not just those who are, not just Purva, but all of you, to write down the possible topics that can be asked from this scenario. So I'll just read out. A 42-year-old male presents with difficulty in breathing, with a heart rate of 120 minutes per minute regular, and his blood pressure being 110 by 72 millimeters of mercury. Saturation was 86% on room air. He was given 40% oxygen via face mask. His arterial blood gas on room air and at a temperature of 38 degrees Celsius is this. You can go through the blood gas thing. I've shared the conversion, the ratio here between kPa and millimeters of mercury if you struggle. And take 1 minute from now. I will set the timer and I will come back to you guys. Okay, so 1 minute is over now. What have you noted down, Purva?
First and foremost, the pH is low. The patient is acidotic. Then
Yeah.
the carbon dioxide is raised. And of course, since you have already given the cursors over there, so it's a bit easier for me. PCO2 is raised, oxygen is low. And as mentioned in the question, his saturation is 86% on room air. So we have given 40% oxygen. That's quite a lot with the face mask. So, and now this is a ABG.
Yeah.
So
Yes. Any other questions that has come to your mind?
He's a young male with difficulty in breathing, having tachycardia. Blood pressure is means almost normal if we'll consider 110 systolic to be normal.
Right. So let me give you a clue here. Now, the experience you've had of like exams back home, DNB, MD, DA, whichever exams you guys have had, boards exam in other countries, do not think that this is the same exam. The format is very different. In there, you're given a starting topic, and then they follow on the same track. That's exactly what I was trying to say, that the exam questions they may start with a question related to this blood gas, right? But followed by, after a minute or so, the format will change completely. You could be asked magnesium. You could, because it's if it's a breathing difficulty, what is the role of magnesium? Explain to me about magnesium. You could be asked about what is work of breathing? Explain to me about work of breathing. It could, so depending on your Viva table, Viva tables are pre-designated. That on one table you will have pharmacology and physics. On the other table you'll have physiology, anatomy. On the next table you have ICU and emergencies, and the next table you have general anesthesia and specialties, all the pediatric, obstetrics, neuro, cardiac, everything. So if your table is, let's say, physics and pharmacology table, normally that is second table. But again, don't put a number to it. You will know which particular Viva is going to start. It will be clear and designated. So think in those terms, that what kind of questions on physics and pharmacology can start from this scenario? What kind of questions can start with physiology and anatomy from this scenario? But I have created 1-minute recollection topics for you guys, which include both clinical as well as non-clinical topics or basic sciences topics. So as I was saying, you have to spread your topics as wide as possible to warm yourself up, to be ready to answer those topics. At this point, you don't have to analyze the blood gas. You can take it won't take you more than 15 seconds to analyze this blood gas. But what you need more than this blood gas is to have a wide idea about where the Viva goes. So have a look at these topics here. Can you guys see it? These are the topics I could think of: mechanism and control of breathing, hypoxic drive, type 1 respiratory and type 2 respiratory failure, effect of oxygen therapy on COPD, oxygen dissociation curve, carbon dioxide dissociation curve, CO2 carriage, work of breathing, lung function tests, restrictive versus obstructive pattern, testing reversibility of pulmonary function, obstruction, sorry. How do you know if it's an obstructive disease? Beta agonist and anticholinergic drugs, CPAP versus non-invasive ventilation, or CPAP and non-invasive ventilation, weaning strategies of COPD patient. So I have still been very much within the realms of this topic. I could have gone way beyond in terms of pharmacology. As I said, magnesium could have been asked, could have asked about humidification. If this was, it could have, the limits are endless. But in that 1 minute, you have to build yourself up for those particular topics of the where your Viva can go. Are you with me?
Yeah.
Yes.
Yes, sir.
Okay. So let's start with your Viva. I'll give you a 10 minutes Viva, 15 minutes Viva maximum, and then we'll talk about the feedback. Okay. So what do you think about this blood gas?
Mixed acidosis, respiratory and metabolic.
So who's carrying on? Is it Purva or someone else wants to give? I tell you what, let's start with 10 minutes with Purva, and then we can rotate to 10 minutes with someone else. Okay. Purva, are you there?
Yeah, I'm there.
Yeah. Let's start with you. First, you tell me what's happening in this blood gas.
As I previously also said that the patient seems to be acidotic.
Yeah.
So it can be a case of COPD, or it can be a case of poisoning. It can be medication induced.
Mhm.
And since there is no mention, means probably the patient is a walk-in patient. We will see.
Okay, sorry.
Yeah, it's okay. We are seeing the patient probably in our PAC or in our emergency setup. The patient is not admitted probably.
No, it's an emergency department. That's a good point. Where it really depends on where this patient presents. That's true. So this is in the emergency scenario, this patient.
Yeah, so most probably it can be a case of COPD, a 42-year-old male presenting with shortness of breathness in emergency.
Okay, fine. So What is causing this breathlessness? You said it's is there hypoxia in this patient?
Yeah, the patient was his saturation is 86%. We are giving him 40% of oxygen, right?
Right. So tell me, what different hypoxias are you aware of?
There are mainly 4 kind of hypoxia, of which I have actually read.
Well, yeah. What are they?
Yeah, one is like hypoxic hypoxia, then there is anemic hypoxia, then there is stagnant hypoxia, and then there is anemic hypoxic, then there is histotoxic hypoxia.
Okay. I'll keep commenting as I ask the questions to improve how you can enhance your answer. So when you're giving the name, give an example as at the same time. What is an example of histotoxic hypoxia? What is this example of stagnant hypoxia? Give an example simultaneously, so it will enhance your answer a bit further.
Okay, so like in hypoxic hypoxia, as the term itself states, there is low partial pressure of arterial oxygen. So it can be because of hypoventilation.
Hypoventilation.
Yeah, hypoventilation.
Okay.
And it can be because of the very common, the ventilation perfusion mismatch. Then the anemic hypoxia is that there is a reduced carrying capacity of oxygen, though the partial pressure of arterial oxygen remains normal over there. So a patient with severe anemia can be an example here.
Okay. Okay.
Then we have a histotoxic yeah, Dr. Danish, you want to say something?
Yeah, I've even enumerated them, and I'll go to the next topic within this Viva, because it's a very fast-moving Viva. You will not get time to
Okay,
settle down.
okay,
So
okay.
next question is, what is the oxygen content in the blood? How do you define oxygen content in the blood?
Carbon dioxide into arterial.
So we're still sticking with Dr. Purva. I will move on. You guys can raise your hands. I will come to you. I will name that person who wants to go next. I think Dr. Anu wanted to be the next volunteer. Dr. Anu, right? Is that yourself, Dr. Kadampa Shrikant? Okay, as well. So whoever else wants to be the volunteer, just put your name as volunteer. Just write volunteer in the chat box, and I will pick you guys. Next one will be Dr. Kadapa, and we will build up from there. Okay. So, Dr. Purva, just continue with your answer. What is the oxygen content of blood?
Oxygen content means the amount of the oxygen that is being carried by
I'm
the.
Mansi.
Yeah.
I'm fine.
It's
I'm fine,
basically.
I'm ভালো আছি।
Sorry, which person is unmuted here? Yeah, carry on, please, Dr. Purva.
Yeah, it is basically means it is represented as C small aO2, if I'm not mistaken.
Yes.
That is the oxygen content.
How do you calculate it?
I'm really sorry, I'm not remembering it right now. Actually, I'm remembering the oxygen the oxygen delivery thing, actually, the DO2, but I'm not remembering CaO2 right now.
What is DO2?
DO2 is the oxygen delivery, the oxygen that is being delivered to the tissues from the lungs.
Yeah. How do you work that out?
Yeah, that is the cardiac output multiplied by the oxygen content multiplied by number, a digit, 0. I think it's 10.
Okay. Okay. Fine. So what are the two components in which oxygen is carried in the blood?
Yeah. No, yeah, right. And I remember. It is carried in two forms. One is the dissolved form, and one is it is carried by the hemoglobin. So the CaO2 is basically the formula that we have read, the 1.34 into the hemoglobin into the saturation plus 0.023 into again then there is again.
So which component is more, with the dissolved component or the bound component?
Bound.
The bound component is more.
Okay. So what is Huffner's constant?
Yeah, the 1.34 in this formula is the Huffner's constant. That is the amount of the oxygen being carried by 1 gram of the hemoglobin.
Okay.
Per
Fantastic.
minutes.
Okay, let's move on to the next one. You got the feel of the Viva, Dr. Purva, because I wanted to give you the feel that this is a very fast-paced Viva, where you pick up one end, and then you lose the direction. It will just flow very, very quickly from one topic to the other. Did you feel that although it started with a blood gas, but you were taken to oxygen content, to different hypoxias and oxygen carrying, how is oxygen carrying capacity and all that. So you were not in that 1 minute, you were not able to put that as the possible question. Neither did I in my 1 minute as a recollection that I had. So this is what you need in that 1 minute to think about all the possible questions that can be asked on that scenario. Yeah, and beyond.
Okay.
Did you find this experience of Viva sort of giving you some sort of motivation that you need, what you need to draw in your preparation? What sort of how should you be preparing? It's not a lot about being in depth. It's all about spreading yourself as vast as possible, answering as quickly as possible. Because in those 25 minutes, they'll ask you 5 major questions with at least 5 subsequent stems. So almost 25 different questions they will be asking you. So you can imagine how fast-paced it's going to be. So far, we've only asked 3 stems.
Okay, so my brain is 40 plus already, so I think I'll have to work really hard.
Trust me, I'm 50 plus, and it's easily achievable. I've had candidates who were 60 plus and they passed the exam. You'll be fine. It's a lot about practicing as much Viva as possible, and you'll be absolutely transformed within a matter of months.
Thank you so much. Thank you so much for this confidence. Thank you.
Most welcome. Most welcome. Right. So, Dr. Shrikant, shall I call you Kadapa?
Yeah.
Okay. So we were at oxygen content and oxygen carrying capacity. What
Okay.
are the factors that influence delivery of oxygen to the tissues?
Cardiac output, oxygen carrying capacity of the hemoglobin, fraction of the inspired oxygen, and partial pressure difference between the alveoli and the blood.
Okay. So if you have someone with hemoglobin of 18 and the other person with hemoglobin of 11, what is going to be the difference in those two patients?
The person with 18 will carry more oxygen when compared to the person with hemoglobin less.
Yes. So do you think that it's still quite good to have a hemoglobin of 18 and to improvise your, what are the other factors that will not be in your favor if you have hemoglobin of 18?
There's chance of risk of viscosity of the blood vessels.
Yes, viscosity, absolutely. So tell me, what are the factors that influence flow of blood through the capillaries?
Its Hagen-Poisson rule, flow is directly proportional to the pressure difference and fourth power of radius, inversely proportional to the viscosity and length.
Okay, so you mentioned about Hagen-Poisson's equation, where what did you say about the radius?
Fourth power of the radius, directly proportional to the fourth power of the radius.
Excellent. So if this patient has higher hemoglobin, will the of 18, will the delivery of blood to the endpoint to the target organ be reduced significantly?
I didn't get pardon?
With the high viscosity of hemoglobin of 18, will it impact the delivery to the end organ?
Yeah, delivery is definitely decreased because of increased viscosity.
So the advantage you got from higher hemoglobin was lost, isn't it?
Yes.
Okay. What do you understand by Reynolds number?
If it is more than Reynolds number determine whether the flow is turbulent or laminar. If the Reynolds number is less than 2000, it is the flow is laminar. If it is more than 2000, the flow is turbulent.
Okay, fine. So how do you work out Reynolds number?
I don't know.
Okay, no worries. What you mentioned about high viscosity. What are the conditions in which you get very high viscosity of blood?
Polycythemia vera.
Excellent. What is polycythemia vera, and how do you? Is there any classification for polycythemia vera?
Yeah, there are type 1, type 2, type 3, but I didn't remember exactly. Polycythemia vera, rubra.
What are the complications of patients with polycythemia?
There is increased viscosity, so there is increased formation of roller formation, so chances of thrombosis will be high. Coronary thrombosis, cerebral thrombosis, retinal thrombosis, renal thrombosis, so end organ damage chances will be there.
So what sort of interventions do you do in this patient?
So this is phlebotomies.
Okay, you if you want to let out blood, that's one aspect. Any particular organ that can prevent, and that removal of that organ can improve your clinical outcomes.
Venous dissection.
Okay, what about spleen? What is the role of spleen in this?
Yeah, splenic sequestration will be there. The splenectomy can help.
Okay, okay. Moving on. Going back to the same scenario where we started with, what is the difference between type 1 and type 2 respiratory failure?
Type 1 is oxygenation impairment. Type 2 is hypoxygenation plus hypercarbia. Both will be there. Type 2 respiratory failure.
Okay.
Hypoxemic respiratory failure is type 1. Hypoxemic plus hypercardic is type 2 respiratory failure.
Okay. So what will be your management of a what do you think is the cause of type 1 respiratory failure in a patient? What are the causes?
Causes will be more of sedation, central respiratory depression. That will be the cause in type 1. Type 2, it will be COPDs, ventilation perfusion mismatch, pulmonary embolism, diffusion impairment, restrictive lung diseases.
Okay. So with type 1 respiratory failure, how would you treat type 1 respiratory failure? What are the ways you can use?
Oxygen supplementation and treat the cause what is causing lower oxygen content. Treat the cause that is causing it mainly, and oxygen supplementation.
So other than oxygen supplementation, is there any other way you can improve the delivery of oxygen?
No, I can't. Someone help.
So what happens in post-operative patient when you find them to be a bit hypoxic? Post-GA patients?
They'll be sedated, drowsy, and hypoxic drive is less in them.
Okay. And what is the role of position of lying down on the gas exchange?
It is lying down. There is a diaphragm relaxation will be there post-GA, so chances of atelectasis will be more.
Fine. So other than increasing oxygen, can you improvise the surface area of the lung? Can you do any recruitment to improve the oxygen delivery?
Yeah, recruitment and we are applying PEEP.
Okay, fine. So,
NIV application.
fine. Okay, I'll quickly pause you here. So in this Viva that you had, you were clearly very knowledgeable. What you need to work on in this particular segment of questions that I asked was structuring your answer. You had a lot of knowledge to pack in those questions. But if I asked you about type 1 respiratory failure and type 2 respiratory failure, what you have to do is to put a structure in your answer. You define what is type 1 and type 2 respiratory failure, which you did. What is the cause and mechanism of that? Based on that cause and mechanism, you can give examples, and then you can give treatment options. That will make your answer with no doubt the knowledge you have is very good. But if you fit that if you fit that knowledge into a particular format, it will look extremely impressive. Did you understand what I'm trying to say?
Yeah, thank you.
Yeah, so in your case, it's more about structuring, or in most people actually, it's all about structuring your answer. We are very good with giving out knowledge, but the format in which it is to be given, that is very, very vital to impress the examiner.
Thank you.
You're welcome. So who was other volunteer after this? Dr. Anu, you want to volunteer?
Yes, sir. Am I audible?
Yes, you're certainly audible. Okay, I will give you another scenario. Okay, this is another scenario. 52-year-old gentleman presents for elective total knee replacement. He's currently on hemodialysis, which is 3 days a week. Try and mute yourself, guys. 3 days a week. He is claustrophobic with face mask and requests you for alternatives. Excuse me. And request you for alternatives where he can avoid a general anesthesia. Now absorb this scenario and try and in this 1 minute, try and think of all the possible questions that can come here.
هم بيدخلوها روحي قولوا لهم يدخلوها الاول الراجل اللي احنا كلمناه وعارف ان احنا هندخلها هيجي يلاقينا ما نيمناهاش وراجل جديد هيعمل لنا مشكله.
So he's a 52-year-old man for TKR.
Sorry. You've had 1 minute?
Okay.
No. Are you ready? We can start if you want. Are you ready?
Yes, sir.
Okay. So just remember from the last example, this Viva is not about focusing purely on this, but on this 1 minute, you have to think as broadly as you can on what are the different topics that can be touched in this particular scenario. And a little beyond as well. So you tell me, what are the things that you have been able to figure out that can be touched upon in this?
So here he's a CKD patient.
Mhm.
So they may ask regarding hemodialysis,
Yeah.
and for regional they may ask regarding ESTA guidelines.
Which guidelines? Sorry, ESRA guidelines.
Yeah, maybe because
Try and speak up a little bit more, because either you're very slow, you're talking very slowly, very low volume, or your mic is a bit far away.
okay.
Yeah.
So I could CKD. Then they can ask me about the options of anesthesia for TKR. What are the other options?
Yeah, excellent. So what are the, you can talk about regional, isn't it?
Yeah, regional. Yeah.
Yeah. What else? Just think as wide as possible. Don't think in a tubular manner. Just think, don't be fixed on this particular scenario. This is what I want all of you guys to think as wide as possible. That will really improve your preparation for this Viva in that 1 minute. Someone has raised their hand. You can either unmute and ask the question, or you can post your question in the chat box.
Consent like informed consent for.
Okay. Okay. Fine. Let me put some of the points which are not comprehensive. You may have a lot more points beyond these. So it can start with the basic science. For example, it can start with physiology of a nephron. How does it work? They can check about the drugs acting on nephron, all the drugs that you can think about in different segments of the nephron. The renin, angiotensin, aldosterone system. They can touch upon that. They can touch upon acute kidney injury, chronic kidney disease, classification of those diseases, causes of those of CKD, anesthetic challenges with a patient in a patient with dialysis or on dialysis, platelet dysfunctions and uremia, fluid balance, hyperkalemia or electrolyte imbalance of any nature, uremia. What are the causes? What are the impacts of different electrolyte balances and uremia on the system? Regional and neuraxial blockades. What are the options of regional and neuraxial blocks in a patient on dialysis? Hemodialysis and hemofiltration, the difference on the mechanisms. Heparin, use of heparin in these patients, and subsequently mechanism of heparin action and uses and doses and everything, and heparin-induced thrombocytopenia. Different types of dialysis, they can ask you about citrate-based dialysis. Okay, so these are some of the things that I could think in 1 minute, but clearly the bigger your list is in that 1 minute, the better prepared you are for that Viva. So make sure you make a big comprehensive list, think as wide as possible. You talked about consent, which is not a bad option. You can talk about consent as well. But in terms of, other than the ethical part of the Viva, talk about the basic sciences. And if you have a structure in mind, if you think, okay, what are the things in physiology that can be asked? What are the things in physics and pharmacology that can be asked in this scenario? What are the things in anatomy that can be asked? What are the clinical options that can be asked in this particular scenario? Then you will be able to put in a lot many points in this particular scenario. Are you guys with me?
Yes, sir.
So the learning point is use that 1 minute in the right way, as much as enhance your sphere in that 1 minute. The bigger your vision, your peripheral vision is, the better will be your ability to face that Viva. Don't go in a focused way in this 1 minute. Okay. So coming back to this particular scenario, what are your choices? What would you like to do in this particular case?
So as this patient is dependent on dialysis, I'll have to and it is an elective procedure.
Yeah.
So we'll have to optimize the patient pre-operatively.
So he's had a dialysis a few hours back. All his electrolytes and everything is normal. His renal functions, his urea, creatinine, potassium, everything, and pH, everything is normal now. So all that is, but focus on this request that he's made, that he wants to avoid a general anesthetic. What are your options now?
So we have to first check whether he had undergone heparinized dialysis. We have to ask for INR, and we have to see the platelet count. And in CKD patients, the platelet function will also be affected. So we have to counsel him regarding the risk of hemorrhage, like risk of
Hematoma. Yeah.
hematoma, spinal hematoma.
Okay.
In case you want to avoid GA. Then if he still wants regional, then the dialysis has to be timed so that the heparin effect, it should be 4 to 6 hours prior to the procedure.
Mhm.
Then
Okay. What are the other questions? What are the other questions you'll ask this patient? If this was someone who you were pre-assessing, what are the questions you would ask other than the information that you've been given and the blood results that you have?
so I would like to know what the etiology of chronic kidney disease, whether he is diabetic, chronic diabetic, and whether he has any complications of diabetes like microvascular or macrovascular. Other system involvements are there.
Yeah. Anything else?
Then I'll take a
That's
detailed system evaluation, because even chronic kidney disease also will have multiple organ involvement. So I will see whether I will see for vitals itself, whether there is any autonomic neuropathy, like patient is having a labile.
Okay.
Uh,
What about fluid allowance? Are you going to ask him about how much fluid is he allowed between two dialysis cycles?
yes, sir, yes.
What about his urine output? Are you going to ask him whether he's anuric or olivuric?
Yes, sir. As
Yeah.
he's yes.
Okay. Okay, fine. So this, coming back to offering him and anything other than general anesthesia that he's requested. So, sorry, I'm just muting other candidates. So if you're offering him other options, if he's asking for other options, you've clearly defined that the risk of hematoma is significantly higher, and that as a result, it's not possible to give a regional or a neuraxial block. Is that correct?
Yes, sir. Considering the risk benefit ratio, we'll have to counsel the patient. Yeah.
So it's very important that you sound confident. You know, the examiner might want to check your confidence in this case. This is a clear case. Giving a spinal is catastrophic in these cases. You know, post spinal, if he goes for dialysis and starts bleeding the next day, you're in trouble. So neuraxial blocks are absolutely no. Regional, yes, of course. If you do peripheral blocks, that is okay, but you do not go anywhere into the deeper blocks in this scenario as well. But you have to be very mindful that any sort of blocks that you do, they have to be monitored later on. Otherwise, there's a high risk of this patient bleeding on and later on. So you stick to general anesthesia and say, okay, regarding claustrophobia, we can do certain interventions to prevent you from feeling that you can hold the mask yourself. We can do nasal oxygenation, high flow nasal oxygenation to pre-oxygenate, and in that case you don't have to be on the mask. So lots of other options to the way you can sort of go into this scenario. If you are giving a general anesthesia to this patient, what would be your approach?
So we have to first confirm the starvation, as it is an elective procedure and he has a chronic kidney disease. We have to they have autonomic gastroparesis are common in this patient, so we will stick to prolonged fasting for this patient. But IV fluid has to be given perioperatively according to his input output. And then I have to tell regarding induction and all those things, huh? Like,
yeah. Okay. Let me stop you here. Let me stop you here. I will pick up next candidate. I'll give you a feedback on this particular scenario that you've answered. So your understanding was quite clear about how to proceed. You were not giving into giving a spinal block or that way. You would definitely score marks, but you have to show confidence. You were low in confidence in your answer. You should sound more confident, and it should, I mean, it should be a much more concise answer. When you say, for example, that this patient cannot have a neuraxial block because of the use of heparin during dialysis, that's enough. You don't have to go beyond those words. Remember, time is of essence in this Viva. It's only a 25 minutes Viva. The longer sentences you speak out or you utter, the more time you waste in your answers. So be minimalistic in your words. Utter those words which will score you marks. Are you with me? It's in this. There won't be much time for discussion. Try and read the examiner's mind, what they're trying to ask. Try and answer exactly the precise word that they're looking for, or the precise sentence or statement they're looking for, and move on. So in this particular scenario, if the question was about claustrophobia and general anesthesia, you would clearly say we can't go with the risks are very high with the neuraxial blocks or with regional blocks. So we would stick to general anesthesia. We will pre-oxygenate the patient with alternative methods, which include high flow nasal oxygen, and proceed with rapid sequence induction. That is enough to score you enough marks to get through the scenario.
Yes, sir.
Okay.
Okay, thanks.
Sir,
Thank you so much.
why can't we go for neuraxial, sir? Wait for 6 hours. It is an elective surgery for mostly unfractionated heparin might be using in dialysis. Wait for 6 hours and check for APTT levels and proceed for a neuraxial blockade. That will be the best.
What about the platelet functions due to anemia?
So that will check the blood levels, APTT and platelet levels. If it is normal,
Yeah. And
Okay,
what about the dialysis the next day?
we'll wait post procedure for 6 hours.
Yeah, but the convention is to avoid, unless there is a really dire risk of patient, if there's a significant risk that general anesthesia itself will kill the patient, you should really avoid giving neuraxial blocks to any dialysis patient. Is that something you guys don't do regularly in your setup, to give spinals to dialysis patients?
No, we'll check the hemogram levels and we'll, if it is normal, we'll proceed with neuraxial blocks.
But my question is, if you come across a patient with hemodialysis in your own hospital, would you put a neuraxial block on those patients routinely?
No, totally depends. Last dialysis was 1 day before and electrolytes are normal, coagulation profile is normal.
Yeah. How many patients on dialysis have you seen which have normal coagulation profile 6 hours or 8 hours post unfractionated heparin? This is not someone who's having heparin for prevention of DVT. This is someone who's regularly been on heparin. The platelet functions, the qualitative function of the platelets is completely gone because of uremia and other factors as well. The failure itself. So the risk of developing complications from bleeding are significantly higher.
Okay.
So don't fall into the trap of saying something which will bring about further, questions on your practice. So do not do anything routinely in your hospital, in your normal clinical work. Try and avoid giving that argument. How many of you guys use spinals for patients on dialysis? Just answer in the message. But if the patient is on dialysis 3 times a week, is it quite common in your practice? I want to see a yes. Anybody there? Yes. So very, very unusual, isn't it? So try and not speak out unusual things. It can be done, as I said, if general anesthesia is going to kill the patient, then that you're only left with that option. And this is an elective scenario, so makes it even more harder to defend that you're going to give a spinal for this. Okay. And in elective knee replacements these days, the trend itself in non-diabetic, non-renal patient, not on the patients with hemodialysis, is towards blocks, general anesthesia and blocks, because of enhanced recovery. So spinal is going out of fashion. Spinal opioids are going out of fashion at the moment anyway in UK. So it's even in the normal elective patient, it's something which is not done that commonly. Okay. Why do RSI? Yeah, good question. Why do RSI in these patients? What happens to their the esophageal sphincters as a result of uremia? What happens to esophageal sphincters in uremia? Gastroparesis is there, of course. Reflux is quite high. Yeah, absolutely. So all uremic patients, all patients with on hemodialysis, you have to do an RSI. Never put an iGel or a LMA. iGel, again, you can defend saying it's what's the word for it? Generation 2 or generation 3. supraglottic device, but definitely not an LMA. Okay, moving on. Who's the next candidate who's volunteered for this? Please unmute yourself and come forward rather than me trying to search through those messages.
May I volunteer, sir?
Yes, certainly. Please introduce yourself.
My name is Dr. Livingston.
Hi, good morning, Dr. Livingston.
Yes, I'm doing a fellowship in trauma anesthesia.
And where are you based?
I am in Chennai.
In Chennai, yes. I think you've been in our Vivas before, haven't you?
I have. Last
Yes.
month, I think.
Yes, certainly. So, Livingston, what's your first name, Livingston?
That is my first name, sir.
It's Livingston, okay. So, Livingston, you come across this patient. What is your plan of anesthesia for this patient?
So I'll counsel this patient regarding the various choices. So as he is claustrophobic and he does not want general anesthesia, I'll explain the risks and the benefits of each option. One is general anesthesia, one is neuraxial, one is regional anesthesia. I will discourage him towards neuraxial anesthesia because of the chances of an epidural hematoma and other complications. So I'll do my best to convince him that even if he is claustrophobic, we would be around him, he would not feel anything, he would go unconscious, he would have no sensation of what is going on. So, and I would try to convince him for general anesthesia with a post-operative regional anesthesia, maybe adductor canal block.
Thank you.
And, I'll avoid a deep-seated block like a sciatic nerve block, but maybe a femoral and adductor canal block along with general anesthesia.
Okay, fantastic. So you have decided, the patient has agreed to having a general anesthesia after you've nicely convinced him. What is your plan of general anesthesia now?
Okay, so I'll first confirm the patient identity and I'll confirm the site since it's bilateral. And once we wheel him off, I'll explain to him that we're going to give him some medication. I will review the investigations done, the last serum electrolytes, the coagulation profile, and then I'll start pre-oxygenating him. I'll ask my assistant to keep the medications ready. For induction, I would use propofol.
Have you put the monitoring? On?
Yes. My assistant by this time would have connected all the monitors, which would include ECG, SpO2, and non-invasive blood gas. I'll calibrate the ETCO2 if I'm using a direct the ETCO2 monitoring. Then I would set my ventilator parameters, and then I would hold a mask, and I would give 100% oxygen first. I would check all the medications which I've loaded up. For induction, I would use propofol. I'll avoid long-acting opioids like morphine. I would go with fentanyl. And I would use, for my relaxation, I would use atracurium. And
bear in mind, this is a rapid sequence induction.
Oh, we are doing, sir, I have a doubt. If the dialysis is controlling his urea levels and his rest of the renal parameters are okay, do I still have to go ahead with rapid sequence intubation?
So you can ask the patient about the history of reflux in first place, but again, if you have an option of preventing any aspiration, why not use that? You will not fail on giving that option. But if the examiner has strong ideas about, so example, myself, right? I'm your examiner, and yesterday I had an aspiration in a patient with dialysis, and if you come and give me the answer that I would go with the atracurium, I would not be very convinced, because maybe my experience over the last few days was not of giving leeway in this particular matter. Whereas if you have ticked all your boxes, if you said, I will go with rapid sequence induction, I will not use sucks because of the risk of hyperkalemia. Now, look at the opportunity you're getting here in scoring more marks. You're saying, okay, you won't use succinylcholine in rapid sequence because of hyperkalemia. I would use rocuronium. I understand that kidney functions are not great, but we have an option to reverse it with sugammadex. You have given out so much knowledge in this particular statement. This was an opportunity where you could have scored more marks, isn't it?
Okay, sir. Yes, sir.
Look at it in that aspect as well, in that perspective as well.
Yes, sir. So in that case, if I'm going ahead with rapid sequence intubation, I would not do positive pressure ventilation, and I would simultaneously give the relaxation agent and the sedative, the agent, which would be propofol and rocuronium, and fentanyl, propofol, and rocuronium. And I would do as much as smooth intubation I could, and keeping all my airway devices and my aids like bougie and stillet ready. I would secure the airway as quickly as possible, and I would connect it to the ventilator. and then I would position the patient with all pressure pads and giving further analgesics as required, like paracetamol.
Okay. Okay.
And even maybe a warmer, a forced air warmer if required.
Okay. Now, a very important point that most of you missed out from the very beginning in this patient. Can someone point out that?
Sir, he was claustrophobic, so we cannot give him a mask ventilation. That was missed
Yes.
in explanation.
Yes, certainly. We discussed that. He said that we will counsel him and see if he can hold the mask. But certainly, yes, if he cannot bear with it, then you either give him some pre-medication or you use high flow nasal oxygen is a good option in that
Yes,
case.
sir. Okay,
Yeah.
sir.
Okay, but something else that you guys missed out right from the beginning, not just yourself, from the previous candidate as well.
Securing IV access?
Yes, it is to do with securing IV access.
You
What
won't
is
secure the IV access on the side if there's a fistula present?
Yes,
absolutely. So how is he getting dialyzed? That's a big question to ask. Is he getting dialyzed through a fistula, or does he have a permacath or some Hickman line or something that is used for dialysis? So obtain that information as well. Yeah.
Yes, sir. Yes, sir.
So that is very, very important that you know which site. If you know that care of the fistula is very important during the general anesthesia, how do you take care of it? You do not want the fistula to become dysfunctional after the procedure, after your knee replacement. So care of the fistula has been asked in the exam previously. How do you take care of the AV fistula in a dialysis patient? It was a separate question earlier in this year or last year. So be aware of this. So as I said, there are so much, try and not look in a tubular manner, try and look around, gather as many points as you can. Then your answer will look really well-rounded, full and well-rounded. That is what you want to deliver on this day. So Livingston, I'll stop you here. I'll give you a quick feedback. I think the manner in which you approached was very systematic. You outlined the options very clearly and gave the feeling that you are a safe and secure, a safe anesthetist. You're giving your communication to the patient looked very clear and sort of straightforward. And then you made a decision of going forward with the plan. The way you were describing about the drugs, drawing out of drugs in a systematic way, the airway adjuncts, manner in which you would do the induction, pre-oxygenation, monitoring, all these things, they have to be in a much more systematic way. But again, try and not be very focused on very important, very sort of obvious things. Look around when you're going forward with the Viva.
Yes, sir. So from this, I've learned that this question has mentioned claustrophobia. So holding the face mask would be an issue I have to address, along with in all CKD patients and in all patients in general, I have to focus on the IV access. Usually we flush the IV access and we check, but in a CKD patient, we have to ensure that the IV access is not in the site where the fistula arm or if there's a HD cannula is present. So I'll make a note of that, sir. Thank you.
As well as blood pressure cuff. You do not place the blood pressure cuff?
Blood pressure cuff as well. Mm-hmm. Yes, sir.
Okay, lovely. Thank you. Who wants to go next in this in the next scenario? We'll start with the next scenario. Guys, who wants to come forward? Yeah. So who would any takers for this? Read the scenario in this 1 minute, and whoever wants to come forward after that 1 minute. Some of you who have attended sessions before, this is a scenario which I've discussed in the past, but it was interesting, so I've used it for this session. 64-year-old male is booked for elective decompression and stabilization of thoracic 8 to 10 vertebrae for a localized spinal cord tumor. His background history is high BMI, diabetes, obstructive sleep apnea, hypertension. The medications he's on is semaglutide, Ozempic for obesity, as well as diabetes, metformin and gliclazide, losartan, atorvastatin. What are the, ignore this bit. What are the anesthetic challenges and what is your anesthetic plan for the patient? They don't give the questions, they will just give you the scenario. So you can just read this, right around the scenario. What are the possible questions that can be asked? And we can start the Viva. Okay. So what are the points you guys have written down so far? Any takers?
Yes, sir.
What's your first name? DSM.
Sir, my name is Deepshika.
Deepshika. Hi, Deepshika.
Yeah. Hello, sir.
So-
Sir, the
Yeah.
topics that came in my mind reading this scenario are obesity and the various problems that are associated with obesity, all the systems that may be involved, diabetes, and in diabetes, what is the control of the patient and what are the various, is there any autonomic neuropathy and other associated problems, the various drugs that can be used in control of diabetes and insulin as well, OSA, obstructive sleep apnea, hypertension, spine. Since it's a spine surgery, then problems of spine surgery, the problems that can be associated with the prone positioning, since it will be in the and the associated complications that can be there. Then regarding blood transfusion, and since it's a it has multi-level involvement, and it's a spine tumor, definitely blood will be required. The problems of blood transfusion. Then it's an obese patient and difficult airway, and problems with the airway, and related to the positioning of the patient, since the patient has high BMI, then he might be requiring special needs while positioning in the OT.
Okay, positioning issue, manual handling issues, yeah.
Yeah.
Okay.
Plus counseling of the patient, because obesity per se, obese patients per se might be having underlying depression or psychiatric issues in general.
Obesity?
Then counseling is very important in these patients.
Obesity and psychiatric issues, something
They might have. I'm just.
a lot of people in this world are obese. Not all of them are psychiatric.
No. Sir, I'm just saying underlying depression, subclinical. It might be there.
Okay, fine. So this is a good summary, and this is what I've prepared, as you can see here. So obesity itself, how you have to define obesity, and classify it, what are the related problems, difficulty in anesthetizing an obese patient with pre-oxygenation, positioning, difficult airway, monitoring, what special monitoring do you need in an obese patient. Then you have other systemic problems related to obesity, not just the respiratory and cardiovascular, but the other aspects that could be associated. OSA in itself is a big topic: definition, classification, stop bank. You should know stop bank at the back of your hand. You should be able to give all the different components of it. What would the patient require post-operatively, CPAP or BiPAP? What does he use at home? What destination should the patient go to after this, if the patient is requiring CPAP or BiPAP? Then perioperative glycemic control. How would you manage with the medications that are that the patient's already on? Would you stop certain medications? If so, how long before the operation, and how long after the operation would it take you to restart them? How would you manage the glycemic control perioperatively? And what are the complications that can arise from those medications? Prone positioning, what are the challenges with prone positioning? What are the complications patients can have with prone positioning? What is the peripheral nerve injury intraoperatively? What are the different forms of peripheral nerve injuries that you're aware of? Abdominal compartment syndrome. What does it mean? What is abdominal hypertension? What is abdominal compartment syndrome? How do you deal with this? So as you see, the Viva is just beginning to open up into its tentacles into different forms now. Thoracic surgery, this is an operation which is done at the thoracic level. which could require one lung ventilation. Surgeon might want to decompress the lung. So double lumen tube, that is something it can go to. Hypertensive anesthesia, the surgeon requests you to deliver that. What are the impacts on spinal cord perfusion? What is the blood supply of spinal cord? What are the watershed areas in the spinal cord? So range of questions that can be asked. Are you with me in terms of mapping out your Viva before in that 1 minute? The huge range that can be asked from. So that is something. My emphasis in today's session is to utilize that 1 minute. Regarding your how you will deliver in the Viva, that comes later on. But your preparation before that Viva is vitally important. If you're able to master that 1 minute and warm yourself up nicely, if your warm up is good, your performance is definitely going to be better in the on that particular session, right? But if you start just being nervous in that 1 minute, what can be asked? What do I do? That will not be helpful. So that is what I'm trying to get at. Use that 1 minute really well to build yourself up for the Viva. Okay, so tell me about this particular case. What would you do in this particular case?
Next one is he's a 64-year male who has come for elective decompression and stabilization of thoracic spine tumor at the level of T8 to T10.
Try not to repeat what is already mentioned here. You will lose time. You conserve your time as much as possible. Examiner knows, you know what has been given out there. Focus on the points that you want to deliver.
Okay, sir. Sir, first of all, the pre-anesthetic checkup of the patient. It will start as the patient comes in the PSC room. Then we'll have the history. History as regards the diabetes, and what is the glycemic control of the patient? What are all the drugs? What is in general? Does he have any kind of hypoglycemic episodes? What is the functional capacity of the patient?
So diabetes, state in diabetes, what is the one very important number that you'd be interested in?
HbA1c.
What should it be?
It should be around 6.5 for a good glycemic control.
So mention that before you. Autonomic dysfunction is important. All those things are very important. Medications are very important, but mention this number. You completely missed out something very important, which in my answer sheet would have given you a mark. Okay. Next thing you're mentioning about after diabetes, what is it that you're taking up?
Then we can go. We'll be assessing for the functional capacity of the patient. What kind of activities does he do on a routine to routine basis? Is he able to climb a flight of stairs comfortably, or he has to stop in between? Does he go for a walk in his daily routine?
Yeah.
And then next is regarding the OSA, the kind of sleep. What is the quality of sleep does he have? Does he have to wake up at night, or does he feel fresh when he wakes up in morning, or does he have any heaviness in his head? The other thing that I'll ask is from the attendant who will be accompanying him. Has he ever observed him sleeping during daytime? Or
so this patient has sleep apnea already, right? It's a diagnosed sleep apnea. Similarly, like as I mentioned in the scenario, it's a diagnosed diabetes, it's a diagnosed obesity, hypertension. So you're not diagnosing this illness. You are assessing the extent of that and what is he using for this at the moment.
Okay, sir. Then has he undergone any kind of sleep study to see the apnea-hypopnea index?
Yeah. Okay.
And is he using any kind of BiPAP or CPAP at night?
So what would you ask about if he was using a BiPAP? What would you ask about him?
So what are the levels? What is the setting of the BiPAP?
What is the setting of the BiPAP? And what would you instruct him?
To bring the BiPAP along with him when he comes to the hospital.
Absolutely. He will need it post-operative. Yes.
Yes, sir.
Okay. So this is getting you marks, right? This is, you mentioned about the use of those devices, those aids for ventilation, and to what settings they're on, and to bring them to the hospital on the day of the operation. Okay.
Yes, sir.
Moving on. Next part.
Next part is hypertension.
Yeah.
What is his control of the high blood pressure? If he has high blood pressure, what is his control? Has any kind of complication related to hypertension in past? Any history of stroke? Any history of any other associated history, like any history of palpitations, stroke, and dyspnea on exertion,
Mhm.
any swelling in his feet has he noted at any point of time, and
Fine. That's good. That's good to me. Okay. Medication history. What would you recommend this patient to have and not to miss on the day of the surgery?
sir, on semaglutide and metformin, sir, actually, we have to instruct the patient to discontinue gliclazide and metformin a day prior to surgery, as well as losartan on a day prior to surgery. Atorvastatin he can continue, semaglutide he can continue.
Okay. What does semaglutide do to these patients?
Sir, it is like sir, it is a semaglutide is.
What is the risk? What is the risk of continuing semaglutide?
Semaglutide cannot be continued. It has to be. It's a reflex high chance of aspiration and regurgitation.
Yeah. And any other complications that can arise by the continuation of semaglutide?
Non-ketotic
Acidosis.
acidosis, non-ketotic acidosis. Sorry. Yes, sir. But sir,
So
one thing I want to ask, like there are some a set of population who is on dulaglutide, which is a weekly injection.
yeah.
We given subcutaneously. What instruction can we give any special instruction to this set of population?
There is a document. I'll have a look and I'll share it in this session about different diabetic agents and the duration for which they have to be stopped. You will get all the details if you're using that injection. Forgotten the name of it. Mounjaro. It's called Mounjaro.
Dulaglutide. Yeah.
Yeah, dulaglutide. Yeah. And so, what is the recommendation regarding that? I don't remember that in the back of my hand, but I'm pretty sure that it has to be stopped a week before at least. So
Okay.
I remember all my patients have been instructed to not take it a week before the surgery, because
Okay.
its role is not in glycemic control mainly, predominantly. It's long term in terms of obesity management and so it won't make a difference. It won't significantly impact their glycemic control, so it can be missed out a week before.
Okay, sir. Thank you.
So this is your the scenario that you've done the pre-assessment part. What is your plan of anesthesia for this patient?
So the plan of anesthesia, it will include it will be general anesthesia for sure, and it under
Before we go there, what are the investigations that you would do, and you would check those what investigations would you check before we go for general anesthesia?
we will go for the complete blood count, renal function test, liver function test, coagulation profile, urine routine examination, and ECG of the patient. If the patient has any history suggestive of any kind of like dyspnea on exertion or any kind suggestive of cardiac dysfunction, then we will go for 2D echocardiography and stress echo if indicated.
Okay.
And then as regards for the respiratory part, we will go for the chest X-ray. That will go for cardiac as well, and ABG, and arterial blood gas sampling. PFT, if the patient has significant problem, then we can go for PFT as well, pulmonary function test.
Okay. Now, what are the things you'd ensure preoperatively before anesthetizing this patient?
So on the day of the surgery, we will first of all look for the fasting blood sugars of the patient, and as well as the urine, check for the urine for the ketones, for the ketone bodies and sugars as well. Then on the day of the surgery, we'll ensure the patient identity. Before taking the patient to OT, we'll ensure the patient's identity, as well as we will look for the fasting of the patient, if the patient is appropriately fasted or not. Because this patient is obese and has a high risk of aspiration as well. Obese, diabetic, so he has high risk of aspiration. So we'll ensure adequate fasting of the patient. Sedatives we will avoid in preoperative area, since the patient can be hypoxic and this may go unnoticed. So we'll avoid any kind of sedatives in the preoperative area. Or if we have to give, if the patient is very anxious, then we have to give it under monitoring. Short-acting sedatives.
Okay.
Then we have, before shifting the patient to OT, we have to ensure our OT preparation first, the appropriate sized OT table, Then difficult airway cart, and difficult airway cart we have to see. All the drugs we have to see. The drugs that we are supposed to give, we have to ensure their availability, as well as any emergency drugs should be present in the OT. We can have difficulty in IV access as well. So we have to ensure a good IV access in this patient.
How many IV access would you consider in this patient?
At least 2, why more?
Okay.
If not, if it's not accessible, then we can go for a central venous cannulation.
Okay. Okay. I mean, BMI 44 is high, but not that high, to be honest. You
Sir,
get
if we
where
find any difficulty like in finding a good IV access, then we can
Yes.
counsel the patient.
For a central line. What are the monitoring would you consider?
So we'll shift the patient to OT, and we'll put the monitors, ECG, SpO2, and heart rate, and NIBP. I would also, after induction of the patient, I would also like to consider for the IBP, invasive BP monitoring
Okay,
in this
very good.
patient, and ETCO2.
What is the advantage of that? Invasive blood pressure monitor?
So invasive blood pressure monitoring will be advantageous to us because first thing, we'll induce the patient in the supine position. There can be fluctuations in the hemodynamics while induction also, and then
But
we'll.
you're doing it asleep. You're doing it asleep, isn't it? So you lose that advantage of induction and the instability during induction that you
Yes,
cannot
sir.
monitor because. But
Yes,
let's
sir.
assume that you've put it asleep. You've done it asleep. What are the advantages that you gain?
Then, sir, after the patient has induced, if we put an arterial line, then during the change of position from supine to prone, there can be fluctuations in the hemodynamics, and also intraoperatively there can be we can expect massive fluid. We can expect.
How accurate is non-invasive blood pressure in an obese patient?
Sir, it is not.
Because of the inaccuracies, that is one reason why you're using that. What are the other
Yes,
advantages
sir.
you will gain out of putting an invasive line?
So intraoperatively, it's a long duration surgery. Intraoperatively, we can get an ABG analysis done for the patient. If there are more than expected blood loss, then we can have an added advantage.
Yeah. So sampling is easier. You can check hemoglobin. You can check gas exchange.
Yes,
right?
sir.
You can check blood sugar.
Yes, sir.
So
Yes, sir. For blood sugar.
Put all these things. You're giving an important information about invasive blood gas, but you're not following up with the points you can score in this. All these points are for blood sugar management, better blood sugar management, better gas exchange management, and checking hemoglobin. It's an extensive surgery with possibility of one lung ventilation. You need good control on the gas exchange, not just monitoring it on pulse oximeter. You can get direct measurement from the blood gas.
Yes, sir. Also, sir, intraoperatively, if we need for hypotensive anesthesia, then also it will be of help for monitoring the blood pressure more accurately.
Okay. So, in terms of prerequisites, you mentioned a lot of things, but you forgot about cross-matching blood. This is a surgery which of multiple levels at the thoracic level, and you might need quite extensive. The patient could bleed, so you have to request for a cross-match. At the minimum, a broken safe, but possibly a cross-match.
Yes, sir. Sir, actually, I mentioned it in the initial plan. The kind of questions the set of questions that I prepared, that I could anticipate. I mentioned there blood transfusion and all, but I forgot while elaborating during the case. That was my mistake. Yes, sir.
No. So because mentioning the point at the right time is important. So when you are in the pre-operative time, that is when you need to ensure that before you put monitoring and all those things, you have to ensure that blood has been arranged. So
yes, sir.
Always important when you're answering such questions, relate to your own workplace. What do you do on a daily basis? Just recall that. Then the information will keep trickling in, and then you will be able to fill your answer with more facts, more pertinent facts.
Yes, sir.
Okay, so you have induced this patient. You're going to induce this patient supine.
Yes, sir.
So what are the How are you going to do that? How do you manage induction in this patient?
Sir, first of all, pre-oxygenation. Sir, we can do it. So we'll pre-oxygenate the patient using HFNC.
High flow nasal oxygen. Why so? It's not a wrong answer, but you have to give me an explanation. Why are you doing that?
So for what? Better oxygenation.
Okay. What else would you do to improve the oxygenation? How would you position the patient?
Sir, in the ramp position.
Ramp position. Say the ramp position is vitally important. What is ramp position, and what advantage would you get out of that? Placing the position in that position.
So we place stacks of clothes beneath the shoulder and the neck of the patient, so that the level of the ears is above the level of the roughly, I should say, it should be at the level or above the level of the chest.
Sternum, right? Yeah,
Yes,
tragus
sir.
and sternum,
Tragus.
right? What did
Yes,
you say
sir.
earlier? What do you place? Clothes?
So stacks of clothes.
Just say Oxford pillow or a ramp mattress. It's
Okay,
a
sir.
much easier thing to say. So just use of Oxford pillow that is used for this, or any ramping device can be used to ramping mattress can be used for this.
Okay, sir.
Okay, so you've done the pre-oxygen. You're doing a pre-oxygenation, let's say with the face mask now. How do you know that the patient has been adequately pre-oxygenated?
Sir, we can also use the inspired oxygen concentration.
What will that tell you?
So the level of oxygenation.
So you're giving 100% oxygen. That's giving you the idea in the
Sorry, sir,
inspired.
Expired oxygen concentration.
Expired. Okay, expired.
Yeah.
Oh, sorry.
Sorry.
So
My
expired.
mistake, sir. My bad.
So
expired oxygen concentration, sir.
what should that be? How much level do you want to achieve?
So more than 96.
More than 90% is fine. Yeah. Okay. Fine. So you've adequately done the pre-oxygenation. You have monitoring in place. You had difficult IV access. You've done that, and you've checked BMs preoperatively. What are the drugs that you would use for this patient? What is your plan of anesthesia, and what drugs would you use?
Sir, I will use for analgesia. I would use fentanyl.
Yeah, fentanyl. Yeah.
And sir, for induction, I would use propofol in a graded manner.
In a graded manner. Okay.
Yes, sir.
So this patient was on Ozempic.
Pardon, sir?
This patient was on Ozempic with gastric stasis, right?
Yes, sir. So I would go for RSI.
Okay. So what is your plan now?
Sir, I would give fentanyl and propofol along with followed by propofol and followed by rocuronium or succinylcholine. Both can be used in this patient.
What dose would you use for, let's say, rocuronium?
So rocuronium is 0.8 milligram per kg.
Okay, ED95, right?
Yes, sir.
Okay. And would you do an RSI in this patient? Would you do a cricoid and suction and everything else in this patient?
So I would straight away intubate the patient then.
You won't do any cricoid?
So cricoid can be, yes, so cricoid can be done.
Just bear with me for a second.
Okay.
I'm just trying to get another examiner in because the capacity is over. The examiner is not able to join in. Right. So sorry for that. So you have you're giving what? Sorry, you what was the last sentence you said?
Sir, we were discussing about the cricoid pressure.
Cricoid pressure, yes. Selix maneuver. Okay. So you're giving cricoid to this patient. You have a suction ready for this case. You have pre-oxygenated. You mentioned about the drugs that you'll use. Are you prepared with any difficult airway adjuncts for this patient?
Yes, sir. Sir, that that we've ensured the availability prior shifting to the patient to the OT.
Perfect. Okay, fine. Okay, Palva has joined in. Okay, thank you. So you've what are your sorry, I'm going a little bit in a random way because I have to give the stage to the next examiner. I'll give your feedback at this particular point before the next Viva starts. So in your approach, you were quite good in terms of starting with pre-assessment clinic, highlighting the different issues the patient has in with diabetes, obesity, hypertension. You were able to go into details of those questions, but there were still a lot of inaccuracies that you have to work on. You have to. This is a matter of brushing up the knowledge and going through guidelines to brush up those inaccuracies. So that is one aspect. Systematic wise, I think you were quite systematic in terms of taking one step at a time. After pre-assessment, you knew exactly what sort of anesthetic plan you would have, what sort of drugs you would draw for this patient, what would be your monitoring plan, what was your anesthesia airway plan, sorry. And you were able to talk a little bit more about the impending complications that you're trying to avoid during the anesthesia. But again, this is a complex scenario, and we went in a straight path in this particular scenario. We didn't diverge into we didn't divert ourselves into different directions as we did in the previous two scenarios, just because this required a lot more information to be shared. But bear in mind that the scenarios change very quickly. What has been shared with you for that first 1 minute may not stay the same. It will just start growing into different directions, and you have to be quite aware and quite ready for it.
Yes, thank you, sir.
Thank you so much. Sorry for the little bit of abruptness at the end because I was trying to manage the other participants. So I'll welcome Palba to our meeting today. Palba is anesthetic trainee in UK. She is working in London, and she passed her FRCA not long ago, about a couple of months ago, isn't it? If I'm not mistaken.
A year ago now, officially.
Sorry?
A year ago, December
Year
this
ago,
year.
wow, it goes fast. Yeah. Yeah. And Palba has been helping us out with all range of Vivas. Her main areas of specialization, which I'd say specialization because that's where we first started, were basic sciences. And of course, she can take clinical subjects as well, but we'll stick to basic sciences today. I would like volunteers to come forward for the next Viva, please. Over to you, Palba. Thank you.
Sure. So just remind me which did you have any specific basic sciences you wanted me to cover?
I've covered very randomly, to be honest. I've been covering a scenario and going into a bit of physics, a bit of physiology and pharmacology, but purely sticking to basic sciences until this last scenario where we were going a little bit into clinical areas. But anything that you want to cover is fine.
Sure. Who would like to start?
Yeah, who would like to volunteer, guys?
And Dr. Anish, what time do you want me to go till? It's 8:45 now.
Until you have about 9 o'clock or 9, 9:15, if that's okay.
Yeah, sure.
Yeah. Okay, who would like to go first? You want to go, Katapa?
Yeah.
Okay, go for it.
Perfect. Okay, do you have any preference on what kind of science you want?
What?
Physiology, physics, chemistry?
Anything is okay.
Anything is fine. Okay. Fine. And it's 5-minute Viva. Okay. Hi, can you please tell me about the physical properties of nitrous oxide?
Nitrous oxide is also called laughing gas. When ammonium nitrate heated to 240 degrees centigrade, nitrous oxide is produced. Okay, it is also called laughing gas.
I'm going to ask.
Its MAC is 104, 104 or 105. Blood gas partition coefficient is 0.47. It is very low hepatic metabolism.
I'm just going to stop you and ask you the question again. The question I asked is, can you tell me about the physical properties of nitrous oxide?
No idea.
Okay, I'll ask you specifically. Can you tell me what the boiling point is?
Boiling point is around 38 degrees centigrade, 40 degrees, no idea.
Okay, critical temperature, critical pressure.
No.
Okay. Fine. What is the MAC of nitrous oxide?
105, 104, 105.
Okay. And what properties of nitrous oxide make it good for clinical use?
Because of its second gas effect and concentration effect, it is cardio stable. There's no much drop in blood pressure, heart rate. There's no much depression in the respiratory rate. So that things make less metabolism in the liver.
Okay. So you mentioned the concentration and second gas effect. Can you tell me what these are?
Concentration effect is increasing the concentration of the another inhalational agent will increase the speed of induction with these agents.
How?
Increasing the room for the alveolar concentration of the second gas.
But what about nitrous oxide? Which feature or physical property of nitrous oxide contributes to the concentration effect?
No idea.
Okay. Fine. Can you explain the disadvantages of nitrous oxide?
Disadvantages? Yeah, it causes bone marrow suppression, vitamin B12 deficiency. It causes combined degeneration of spinal cord. It is lighter than the nitrogen, so chance of entering into the air cavities is high. So it is contraindicated in laparoscopic surgeries or inner ear surgeries. It inhibits DNA synthesis. It causes greenhouse effect.
How does it elicit its analgesic effect?
It is a good analytic. Nitrous oxide is a good analytic.
Yeah, can you explain the pathway by which it delivers the analgesic effect?
It inhibits the release of substance P at the dorsal horn of the spinal cord.
Okay, good. Can you define volume of distribution?
Volume of distribution is the amount of drug injected to the plasma concentration, or dose of the drug injected to the plasma concentration.
What do you mean by that? Sorry. So it's a volume of distribution. What does that mean?
How widely it is distributed in the body. I mean to say
Mm-hmm.
amount of drug injected to the plasma concentration. That is the equation.
So that's the equation on how to yeah, I'm not asking for the equation. Can you define what volume of distribution is? What is it?
How it is distributed widely in the body.
So I'm asking, it's volume of distribution. You're saying how it's distributed, but what is the volume of distribution?
No idea.
Okay. What are the factors that affect the volume of distribution of a drug?
Lipid solubility, protein binding, size of the molecule, concentration gradient, ionization.
Okay. And what is elimination half-life?
Elimination half-life is amount of the drug is eliminated per unit time from the entire body.
Sorry, I think there's
amount
some
of the drug is eliminated from the body.
Okay. The amount, so elimination half-life, you said, is the amount of drug eliminated from the body.
Yeah.
Anything else you want to tell me? Okay.
No.
What is context-sensitive half-life?
Time taken by the plasma concentration to reduce to 50% of the infusion have been stopped.
Okay, good. What is the significance of the effect site and the plasma site concentration?
Pardon, voice is not clear.
Sorry. What is the significance of plasma concentration and effect site concentration, CP and CE?
Effect site concentration is the brain, and plasma concentration. We use these models in TCA pumps, effect sites and plasma site concentrations. Effect site concentration is the brain.
Okay. So how do these two compare at induction? CP and CE, which one is greater at induction?
At induction, CP is greater.
Okay. At maintenance?
At maintenance, it will be equilibrium. Drug will be distributed from CP to CE.
Okay. And at emergence?
And an emergence, drug will be redistributed back to the plasma concentration. So CP will be more than CE.
At emergence, CP is more than CE?
Drug is eliminated. CP is less than CE.
Okay.
Yeah.
Can you measure the CE of propofol?
No.
Why not?
No idea.
You said no. You're right, but why not?
Because it is a rate that the TCA model will adapt to reach that effect site concentration, what we keep, but we can't measure.
Okay, good, fine. What is CP50?
What?
What is CP50?
Time taken for the plasma concentration to reduce 50%.
Are you sure? First of
Yeah.
all, I've asked you CP50. Do you think CP50 is a time variable or is it something else? You just told me what CP
Concentration
is.
variable.
Okay, fine. So it's the plasma concentration at which point?
Plasma concentration. Pardon, question is not clear.
Okay, we'll move on. I'll tell you later. Okay, what are the advantages of Viva and what is Viva?
It is in giving anesthesia, total intravenous anesthesia. It is completely avoiding the inhalational agents. So side effects of the inhalations will be like nausea, vomiting, environmental pollutions can be come down with Viva. That is the main advantage.
Yeah, anything else?
We can predict the outcome of the patient.
Okay, arguably you can do that with SIVO as well, to some degree, but go on. Anything else?
No.
Okay. What is first order and zero order kinetics?
First order kinetics, constant fraction of the drug is eliminated from the unit time. Zero order kinetics, constant amount of the drug is eliminated from unit time.
Good. Okay. What is the Michaelis-Menten equation?
pH equal to pKa plus log pH equal to pKa plus log weak base by weak acid. Is that true?
Which equation did I ask you for?
My cousin, sorry, I forgot.
Okay, that's fine. Okay, fine. We'll stop there. That was 10 minutes. Okay. How do you feel that went?
It's a basic sense, somewhat weak in basic senses. That's okay.
I don't think you're weak. I don't think you're weak. I think you have a lot of knowledge, but you just have to. There's a few things that you need to do. So I'm just going to give you some feedback. Okay, I'm not going to tell you all the good things. You have lots of knowledge, and you can produce that, and you're fairly clear in the way you speak. Okay, the things that you can improve, you need to listen to the question. Okay, I think it's happened 2 or 3 times that I asked you a question. You heard Michaelis-Menten, you gave me the Henderson-Hasselbalch. When I asked you about the physical properties of nitrous oxide, physical properties, you told me how I can produce it, how it's metabolized, but you didn't give me the physical properties. Yeah, you won't get marks if that happens because they might not have that. You know a lot, but there's a way of presenting that. There's a very clear distinction between the answers that you do know and the answers that you don't know. You need to change that completely. So it should be so much that it's Can somebody please mute the interference?
هو بطيء ده لسه ما فتحش وهو وليد راح فين
Can everybody please mute
مجاز يعني مش هيحصل وحبكي الاستبلامات كلها تيجي لما وليد مشي يعني ده انتوا بتنشنوا يعني
Okay. Fine. So yeah, knowing how to answer those questions is important. When I ask you a question, you're giving me the answer like this. Okay, it's good. You know a lot, but just slow it down a little bit and tell it to me like it's a story. Okay, like you're explaining it to me. I'm sorry, I don't. 1 second.
طالع ما يكسبه بيضيع الشيء بدري ضيع هو ايه طالع يشوفها هيدي مزرعه ابو يخلف طالع الممكن وعندنا نروح للتجاره يا سيدي انا كل ما اطلع بشتري من عندها عندها تنور صغير.
Do not say no idea. You don't know the answer. Don't say no idea.
تنور
You're not hearing me. 1 second. 1 second.
ما شايف شيء جديد.
Okay, fine. Okay, I think we're there now. Thank you, everyone. Okay, so if you don't know the answer to a question, don't say shake your head, say no idea. No, you have to learn to be able to say something. Like there is knowledge that you have. You have to answer the question. If you don't know anything about the question, say, okay, I'm not sure about that, but I do know this. Maybe that will give you the marks. Maybe they'll say, no, you have to do this. But there's better ways of saying no idea. Then that's like you won't get any marks for that. Yeah. When I ask you about, say, for example, what is TIVA? What are the advantages? Yeah. So you say TIVA is total intravenous anesthetic, like you said. and then classify your answer. Any question that you can classify, classify it. So in this one, you could have said TIVA's advantages can be divided into patient factors, surgical factors, anesthetic factors. Anesthetic factors can be like post-op nausea, vomiting, and its use in malignant hyperthermia, and its use outside the theater environment for transfer medicine. Surgical, ENT procedures, gynae procedures, whatever, like orthopedics, it's got its benefits there. And then patient factors, you can talk about all the benefits of patients. So then that way you have a little bit, and it seems like you know so much because you know these things. It's not like new knowledge. But if you just say, oh, post-op nausea, vomiting, analgesia, and then you stop, there's so many advantages of TIVA, right? And you mentioned like pollution and things as well. So just have a think about that as well. Any question that you can classify, do it, because it makes it seem like you have a lot more knowledge. And anything that if you get a question that you don't know the answer to, if you've classified it, you will come up with more ideas of what you can say.
Okay.
Does that make sense? Yeah?
Yeah, thank you.
Okay, no problem. That was good. It was good. But just my biggest thing is just slow down a little bit as well and listen to the question. Okay, good. No worries. Who'd like to come next?
I'd like to volunteer more.
Yeah, sure. Please come on video. Can't see you. Sorry, 1 second.
Who's the next candidate?
I'm here. Good morning. My name is Josiah.
Josiah, yeah. Where are you from?
From Lagos, Nigeria.
Perfect. Welcome to the session. Yeah. Okay. Yeah, Josiah. Okay, we can see you here.
Okay, perfect.
Can you see the participant, Palma?
Yeah, I can.
Perfect.
Just trying to not do any more. Is it? Give me 1 second. Okay.
When is your exam, Josiah?
I plan to write around May next year.
Okay, of course. Sorry, it's a silly question. The exam dates haven't opened yet. I asked it a bit beforehand.
Okay. Hello. Can you tell me about the ASA scoring system?
Okay. The ASA scoring system classifies patients into different categories from ASA 1 to ASA 5. ASA 1 patients, they are normal healthy patients that the indication for surgery is just located at the site of the surgery, no systemic illness. ASA 2 are patients with mild systemic illnesses, for example, patients with well-controlled hypertension, well-controlled diabetes. Then ASA 3 patients are patients with severe systemic illness, but not incapacitating. Example, a patient with uncontrolled hypertension or uncontrolled.
Did you say ASA 3 is severe systemic disease?
Yeah, they have severe systemic
okay,
illness.
then what's ASA 4?
So ASA 4 are patient with severe systemic illness that is incapacitating.
So what's the difference between 3 and 4?
So the difference is the word incapacitation. In ASA 3 patients, they could manage to move around. There is no functional limitation per se. But in
there's
ASA
no
4,
functional limitation in ASA 3.
yes.
Okay. What about ASA 6?
ASA 6, they are brain dead patients.
Okay. What are the indications for pre-medication of patients?
Indications for pre-medication, it includes anxiolysis. It helps to reduce patients' anxiety. Then it can also be used to help patients to tolerate the procedures in the operating room. For example, children that are coming for general anesthesia, pre-medication will help them to be able to tolerate the face mask. And,
okay, so anxiolysis is one. What else?
It can also help to prevent sympathetic response during surgery. For example, patients that normally have elevated high blood pressure or tachycardia in the perioperative periods. pre-medication.
Okay, so say we give like benzodiazepines, anxiolysis, those kind of things will have that kind of, okay, fine, you'll have a smoother induction. What other drugs do we give as pre-medication?
So the drugs that we give as pre-medication includes benzodiazepines, for example, diazepam or midazolam. We can also use.
Let me ask you a wider question. So I'm saying, have you ever given paracetamol as a pre-medication?
No, I've not.
Okay. Anything else that you might give, like omeprazole, sodium citrate? Ever give those as pre-medication?
Yes, in pregnant patients who are at risk of aspiration of.
Okay, so what's the purpose? So what's the purpose of that pre-medication?
Okay, for example, in patients that are pregnant, because they are at risk of aspiration of gastric contents, we want to use, increase the gastric. We want to ensure that the contents of the stomach is decreased by using proton pump. By using prokinetic agents, for example, metoclopramide. We can use acid suppressants like non-particulate antacids, sodium citrates. We can use proton pump inhibitors to reduce acid secretion.
Got it. Okay. I'm going to move you on to the next question. What are the indications for monitoring ICP?
The indications for monitoring raised ICP, it could be in the intensive care units, it could be in the operating room. In the intensive care units, patient with traumatic brain injury, it could be done to monitor their ICP.
Okay, and how do you monitor ICP?
It can be monitored using several methods. For example, intraventricular drain, use of subdural drain, use of extradural drain. They can.
Okay, so drains. Anything else?
It can also be done clinically based on clinical signs of raised ICP. For example, if there is associated vomiting, if there's associated bradycardia or headaches or diplopia or visual impairment, they could be pointers to raised ICP.
Okay, good. And what is normal ICP?
The normal ICP should be it should be less than, is around 10 to 15 millimeters of mercury.
Okay. What are the basic principles of pulse oximetry?
Okay, the basic principle of the pulse oximetry is based on the absorption of infrared based on the Beer-Lambert law. According to the Beer-Lambert law, it says that the amount of light that is absorbed, okay, it splits into two, the Beer's law and the Lambert's law. So the Beer's law says that the amount of light that is absorbed is directly proportional to the concentration of the solution in which the light passes through. While the Lambert's law says that the amount directly proportional to the length is directly proportional to the length parts of the lights. So for the pulse oximetry,
is it directly proportional or is it inversely proportional?
Is directly as the length the light passes through increases, the amount of light absorbed increases.
Absorbed increases. Okay, yeah, fine. Okay. What is the response time for a finger probe?
The response time for a finger probe is less than 5 seconds.
Are you sure?
Not quite sure of the number.
Okay. What are the limitations of pulse oximetry?
Okay, the limitation is that it cannot be used to monitor ventilation. For example, a patient might be hypercarbic and still have a normal oxygen saturation. Then it can be affected by ambient lights. It can be affected by some conditions like nail polishes. I think these are the common ones.
Okay. Fine, we'll stop there. How did you find that one?
Yeah, it was interesting. I feel I had something else in mind, and the questions went to areas I wasn't expecting.
Yeah, I basically covered 3 topics in those 10 minutes because some of these questions are also drawing graphs, which will take a bit of time. It's fine. I think you, again, like you have good knowledge. I feel like you need to engage me a little bit more. These examiners are seeing lots and lots of people every day. And so like, I know it's hard through a screen, but like a little bit more animation, a little bit more like, you know, not speed necessarily, but like, it's like I'm asking you these questions, like it's a conversation, you know? So for example, if I ask you about, what are the basic principles of oximetry? Like you start with like an opening sense. So pulse oximetry is based on spectrophotometry. It's described by the Beer-Lambert law. The Beer law is the intensity of transmitted light decreases exponentially as concentration increases, and Lambert's that. And then you stop. You know, it's like more of a conversation. Then I ask you the next question. It felt a little bit like the energy level was a little bit low. And I know this is not like a very technical thing, but it will be more engaging for the examiner if they're able to speak back and forth. Because then a few times I tried to stop you or move you to like another part of the conversation and you weren't really listening to me, or you just carried on talking. And that will mean that you lose time in a very short station. So if the examiner is trying to tell you to go another way, listen to them and try and take their lead because they're trying to give you marks. Yeah?
Yes, ma'am. Thank you.
No, that's okay. The other thing I was going to say is, yeah, when I'm talking about pre-medication, try if you ever get stuck with a question or somebody asks you something like, oh, but what about this? Try and go a little bit broader. So think about like pre-medication technically is anything you give to a patient before anesthetic, right? So then when I said like, oh, so then you're like, oh yeah, of course, reduce aspiration risk. But again, like make it a bit more engaging. Like this is used, like you said, in obstetrics, it can reduce the aspiration risk. The other thing is like analgesia, so paracetamol, at least over here for children, we give them paracetamol and ibuprofen preoperatively to give them analgesic pre-medication. Yeah, I liked that when I asked you about ICP measuring, you talked about both the ICU and the OR. That was a very nice way of opening the statement because I was like, okay, so you know about the different places, and then you told me about the ICU and you told me, you know, what about Cushing's reflex? But you came up with it yourself, which is good. It's that same thing when I say, how do you monitor ICP? Some people will just say, okay, you know, extraventricular drains, pressure transducers, whatever. Whereas you'd step back and you said, okay, there's clinical and there's interventional. And then you tell me about both. Yeah, that makes sense. That's good. The time lag for a pulse oximeter is about 15 to 20 seconds. So if you have a desaturation, this is one of the limitations. If you have a desaturation when you're looking just at the finger probe, you might not see the desaturation until like 30, 40 seconds. Yeah?
Yeah.
Perfect. Any questions?
No questions. Thank you.
No worries. Well done. It was good, but I think you just need to just like try and practice like having a conversation more. Like practice talking to your friends and telling them about anesthesia.
Yes, ma'am.
Okay.
Thank you.
No worries.
I think the first vibe is always the most difficult one to face, and then it gradually gets easier and easier. But unless you really step yourself into that role, you wouldn't be able to go further. So well done for doing that. Well done.
Thank you, sir. Thank you, sir.
And thank you so much.
That's fine.
Yeah.
Did you want to add anything?
No, I think it was going fine. I was not there all the time, but I was listening to bits of it, which I think it was good feedback to let him grow into a much more full on Viva candidate, because he has knowledge. It's just how to present yourself and how to sound really confident. That's a key thing.
To be honest, that's most of the exam, unfortunately. Like it's not even about how much you know. Everybody knows, like you all know a lot, but it's about how presenting it, because the examiners don't know how much you know, and it's about presenting it in a very, confident and composed way that gets the marks.
Absolutely. I mean, you come across a lot of training. You've done your medicine from UK, and you've seen how the system in the Western side works. It's all about how you articulate yourself. No one really understands or cares about what papers you've written, how many books you've read, but on that particular topic, how well presented you are. That is really the most important part.
Yes, exactly.
Lovely. Thank you so much, Valpa, for giving out your early morning hours on a Sunday, and really appreciate that.
It's fine. I'm still at work. I've been on the night shift, so.
Oh, oh my God.
Yeah, yeah.
Well done to stay really calm and relaxed despite a night shift. Thank you so much for that, and have a safe drive back home.
Thank you. Good luck, everybody.
Thank you. Bye-bye.
Thank you. Bye-bye.
Thank you.
Okay. Right. So now, guys, it's very important that we make this session. We're about 95, 96 people in the session at the moment. We want your participation, and that is how you will all benefit from it. Just listening is not going to help. So if you have the chance, and if you're not at work and you can participate in this session, come forward and experience it. You know, there's no point in window shopping. There is a big sale running here. You don't need to window shop in the sale. Grab the stuff that you want. Grab the opportunity. So come forward. Nobody's going to judge you that you do not know a particular topic. We're all in the same boat. Nobody is an expert on anything. Some may know a little bit more, some may know a little bit less, but we're not here to judge or evaluate anyone else. We're here to help each other to pass this exam. And that passing of that path to pass this exam comes from this attitude that you do not judge anyone and you focus on your target, that is getting through. So come forward with a focused mind to get through the Viva that is presented to you. I would like to invite Dr. Dikshita, who is going to take the next hour, 2 scenarios from now. And I'd like to invite at least 2 candidates, one after the other, who will be facing her. So who am I having as the first candidate?
May I volunteer, sir?
Yeah, certainly.
Yeah, this is Livingston again.
Yeah, it's Livingston, right? Yes, Livingston. Please come forward. And
Yes,
I will pass on.
I'll come, sir.
Yeah, who's the next one?
Nirupma.
Nirupma.
Yeah.
Oh, Dr. Nirupma. Hi, how are you?
Yes. Yeah, I'm fine, sir.
Good. Perfect. So over to Dikshita. Dikshita, are you here?
I'm here, sir. Good morning, good afternoon for the different time zone peoples. I am sure you would have had an exhaustive session until now. Hopefully, we will make it more interesting. And you've already had a taste of the previous session and how it goes about. We'll slightly modify the session now. And we will first display the question. You'll have a small preparatory time of 1 minute, followed by the Viva. Then after the Viva, we will display the points which you could have probably thought of during your preparation time. Okay, so we'll run through this kind of scenario in the next couple of hours.
Yes, ma'am.
So without losing much time, sir, can you display the first Viva?
Yeah. Sorry.
Yeah, if you could zoom it, sir. Meanwhile, I'll read out the question to all of you. We have a 32-year-old male with no known comorbids brought to the emergency department with new onset palpitations, dizziness, loss of consciousness, okay? And he's had, because of this, he fell in the elevator over his face, like head-on injury. During this fall, he injured his neck. He was brought to the hospital, and now he has weakness in all 4 limbs, quadriparesis. He was cardioverted twice in the ambulance. On further evaluation, he was found to have free T4 levels of 61.1 with a normal range between 12 to 22 picomoles per liter, TSH of less than 0.005, okay, it's way less than the normal range. And on further imaging, MRI showed post-traumatic cervical spinal cord contusion with marked stenosis at C3, C4, and C4, C5 level with cord compression secondary to large disc protrusion. So your 1 minute time starts now.
Twice.
So I think time is up, sir.
Yeah.
Yes, ma'am.
Yeah. So Dr. Livingston, right? If I'm not wrong.
Yes, ma'am.
Yes, Dr. Livingston. What are your important concerns, or what is the current diagnosis in this patient? You are the anesthetist on call. You have been called to the ED for this patient evaluation because he's planned for a emergency cervical spinal cord fixation. He's planned for an anterior cervical decompression and fixation.
Yes, ma'am. So my primary concern would be his airway and maintaining his cervical spine. So I'll ensure that a cervical collar, preferably Philadelphia collar, is placed with minimum cervical movements.
Okay.
What is the GCS of my patient? Is he awake?
His GCS is 15.
His GCS is 15.
Currently hemodynamically stable with a fast ventricular rate, fast heart rate.
Fast heart rate. So I would like to get a 12-lead ECG done for him. And at the same time, looking at his overall picture regarding his thyroid profile, it looks like he is an uncontrolled patient with hyperthyroidism. So if in this case, it could be that a ventricular tachycardia or ventricular fibrillation precipitated his syncope, which led him to have this fall. So I'd like to have preferably, I'll like to get a cardiologist involved and endocrinologist involvement as soon as possible. I'd like to inquire whether a beta blocker is applicable, and I would like to have, prior to shifting him to OT, I'd like an invasive line to be placed if time permits in the ICU, as well as central line placement. And I'd like to discuss with his relatives about the condition of the patient. So mainly his airway has to be controlled, his cervical collar has to be controlled, and the venous access as well as his cardiovascular status is to be optimized.
Okay, you spoke about the airway, you spoke about the cardiovascular status and the cervical spine stabilization. Any other important concerns, specifically concerning the level of injury?
So because this is a high cervical cord injury, there's a high risk for him to go into respiratory failure. So preemptively, I'd like to intubate him and put him on a mechanical ventilator, because his diaphragm would not be effectively able to ventilate. And I'll also discuss with relatives of long-term tracheostomy and ventilatory care.
Okay.
Along with that, I'd like to arrange blood for the surgery.
Okay. Any other preparation you want to do? So what are the 3 important scenarios you're dealing with?
So this is a high cervical cord injury. This is a patient with uncontrolled thyrotoxicosis. And this is a patient with a tachyarrhythmia. So I would like to, since he is having a fast ventricular rate, a beta blocker infusion or a midurone infusion, I'd like to discuss this with a cardiologist, whether it's feasible. Along with that, an IVC filter at the later date, because he'll be immobilized in bed. So to prevent that comes later.
So do you, if all bedridden patients, do you go for an IVC filter?
Ma'am, in our institute, this is being done regularly. Patients with cervical trauma, we prefer to have a IVC filter placed, because along with DVT pump and Clexane will be given.
Okay.
But this is what is practiced in my institute.
Okay, got it. No issues. Go ahead, further down. Yeah. So what else preparation would you want to do preoperatively in this patient?
So I'd like to control his thyroid status by giving carbimazole and Lugol's iodine along with propranolol.
Which do you want to give first?
First, I'll give propranolol, Lugol's iodine, then I'll give carbimazole.
Okay, so you want to give propranolol first, followed by Lugol's iodine, and then you want to give carbimazole.
Yes, ma'am.
Okay, so you have given him propranolol first, okay, and then you have given him Lugol's iodine. Okay, when your pharmacy is getting prepared the carbimazole, okay, you see there's a further aggravation of his atrial fibrillation. Why so?
I think because I've given propranolol first, then I have given Lugol's iodine. So I think the pre-synthesized thyroid hormones have been released.
Okay.
So that I made a mistake. I should have messed that up.
Yeah. So which will you give now first? Will you give Lugol's iodine first, or will you give carbimazole first?
Carbimazole.
Okay, you'll give carbimazole first. Okay, so suppose I say that his GCS is not that good, that you cannot give him through the oral route. So
I have to put a nasogastric airway.
Okay.
So
nasogastric airway.
Sorry, my mistake. NG tube.
NG tube. Okay.
Nasogastric tube.
Any other routes you can give it through?
Orally, if he's able to, but his GCS is poor.
Yeah.
Nasogastric or orogastric tube. I mean.
Okay. Do you have any IV preparation of antithyroid drugs?
Other than metamazole, carbimazole, Beta blockers, diuracil.
Yeah, so among the drugs which block the synthesis of new thyroid hormones. Okay, so do you have any drug which can be given in the parenteral formulation?
Steroids, no, I think dexamethasone to prevent conversion of T3
Peripheral conversion. Okay, go ahead.
But to answer your question directly, I'm not sure, ma'am.
Okay, which of these antithyroid drugs would you avoid if the patient was pregnant? A female patient being pregnant.
I'd avoid carbamazole.
Okay, fine. So how would you overall classify the antithyroid drugs?
I would classify the antithyroid drugs into drugs that inhibit the peripheral conversion to T4 to T3, drugs which reduce the release of preformed thyroid hormones, drugs which inhibit the synthesis of thyroid hormones, and anything else.
Okay, so these are the main
that also comes into classification.
Okay, any other drugs, any other preparation you want to do before you start the surgery?
Any other preparation I would like to do before the surgery? 42-year-old male, no comorbidities, presenting with uncontrolled thyroid storm with high cervical injury.
You mentioned about your 3 concerns, right? So
yes,
for the 3 concerns, would you want to do any specific preparation? You spoke about the thyroid a lot now. What about the rest of the 2?
The airway and
yeah. So what are the preparations you want to do for all of them?
So for the airway, I would preferably like to do a awake fiber optic intubation. I will counsel the patient about the need for this. I'll explain to him that I'm going to give nebulized lignocaine. I'm going to spray his throat with certain preparations to make his throat numb. And
any alternative for the awake fiber optic?
Manual inline stabilization with the CMAC laryngoscope with minimum cervical extension. And I'll have my senior present with me in case I can't do it. Along with that, I would use a short-acting neuromuscular agent in case I cannot control the airway.
What do you mean by short-acting neuromuscular agent? Which agent, be specific?
Either succinylcholine if his potassium is okay, or rocuronium. But if rocuronium, if I'm not able to intubate, then I'll have to have my other adjuncts ready, like supraglottic device, to ventilate him if I cannot intubate him.
Okay.
And
so what is your concern with this patient? Because you're doing an airway along with other issue of him. Are you concerned with anything else?
Yes, ma'am. Since this patient is already hypothyroidism and in tachycardic state, I would like to give preferably esmolol or intravenous lignocaine or magnesium, something to blunt the tachycardic response in my laryngoscopy. Perhaps some fentanyl, 1 to 2 microgram per kg. So I would not like to be how do I explain this? My intubation has to be as smooth as possible. It has to be quick as possible. And I should not cause tachycardia to precipitate a VF or VT.
Okay. What are the various monitoring you would need in this patient?
For this patient, I would like to have invasive blood pressure monitoring, as well as neuromuscular monitoring and temperature as well.
Okay. Anything else?
Along with that, the standard ASA monitoring, SpO2 and the ECG, along with what is I missed?
Okay, so during the procedure, you notice that he ends up in atrial fibrillation with a fast ventricular rate. Okay, and he has become unstable. Now, what do you want to do?
I have to keep my defibrillator ready. I'll instruct my staff to keep the defibrillator ready, and I'll have to cardiovert him, ma'am.
So, did you apply the pads before starting the case?
Yes, ma'am. I should. Yes, I would have.
Yeah.
Hope I did. So,
so that is what I was asking. What is the additional preparation you would be doing?
Yes, ma'am. Definitely.
Okay. So now that this patient, what is your plan for the post-operative period?
So the post-operative patient, as this is one important thing I missed out, was my pre-operative assessment. I like to assess his cough reflex and how his breathing pattern is. If this patient will not tolerate extubation, I would like to shift him with the tube for post-op ventilation. And if we
so would airway and your breathing pattern or the involvement of the diaphragm would be the only deciding criteria for your post-op extubation or elective mechanical ventilation, or anything else in this case?
Because if it's a high cervical cord injury, these patients, they tend to have a troublesome weaning period. So either a tracheostomy we would do intraoperatively, but I do not feel extubation would be a wise measure for him, because he'll have a poor cough reflex. He will end up with atelectasis. Then there will be ARDS and hypoxia. So
so if this same patient presents to you about 2 years later okay, and he's still quadriparetic, okay,
Yes, ma'am.
and he's bedridden. So he presents to you for a bedsore debridement. What are your main concerns now?
So this bedsore bedsore in the gluteal or in the thigh region. So he is presenting me with otherwise controlled thyroid status and other issues. The only comorbidities right now is his quadriplegic state because of his high cervical injury.
Yes.
Okay. So for this patient, I will avoid giving succinylcholine because of the presence of extrajunctional receptors, and which will cause hyperkalemia. Along with that, I would preferably go for a short Viva.
Okay.
Or a spinal anesthesia, depending on the duration.
Anything else in this history is important for you in this period of interim of 2 years?
In the 2 years, the presence, I have to rule out pulmonary thromboembolism. I'll do a DVT, the lower limb Doppler, venous Doppler, to ensure there are no clots. And I will just take a brief history, whether he's receiving physiotherapy regularly, whether chest physiotherapy is being done. I'll assess his vital capacity, his how well he's able to breathe.
Okay. So you're talking more of the sensory, the motor. What is the important concern for a chronic spinal cord injury patient?
Autonomic dysreflexia.
Exactly. What is it? What is autonomic dysreflexia?
So in lesions about T6, these patients tend to have a wild fluctuation in the sympathetic the system on stimulation. So if he perceives pain in the area which is denervated, this will be accompanied by hypertension as well as tachyarrhythmias. So I have to ensure that his blood pressure, his autonomic system is functioning properly.
Okay. So how would you ask about this in the history?
I would perform a Valsalva maneuver I would like to do, but history-wise, the temperature, whether I'm not sure, ma'am. I'm not sure.
Okay. See, okay. So you mentioned about the triggers being if there is any stimulation in the denervated zone, if it's causing pain. Any other triggers you're aware of?
Other than surgical stimulation, it could be precipitated by infection. No, ma'am, I'm not sure. What is the answer?
Okay, I'll discuss that. No issues. Fine. Okay, we'll stop the Viva here. How do you feel, Dr. Livingston?
Not very good, to be honest.
Okay. Danisha, you're on board?
Yes, I'm on board. Shall I share the...
Yeah, can you share the points to be discussed? Okay, Dr. Livingston, first and foremost, you started off very good. Okay. You went in a good pace. Your the important concerns in this particular patient, you could highlight that. Okay. So when you're doing this, if possible, anyways, you'll have a blank paper with you, wherein you'll write down the question and you'll prepare the points to be discussed in the 1 minute break. I mean, you usually have a 10-minute preparation time, if I'm not wrong. I don't know if it's reduced now, but as far as I remember, you get a 10 minutes of preparation time. So in that time, you jot down all the points you want to which you think that they would probably discuss upon. That is one thing. Second thing is, since you told about 3 important concerns in this particular patient, one is airway, second is his thyroid status, third is his cardiovascular status. So make it as a 3 flow chart so that every time, be it preoperative, be it intraoperative, and then your plan for the post-op, you are able to highlight these 3 important. You should not miss on it. If you remember, during the Viva, I was trying to again remind you of the 3 important concerns. You were focusing on one particular concern, you missed on the other 2, right? So I don't want that to happen. If possible, you make a flow chart so that you don't miss on them. That's first thing.
Yes, ma'am.
Okay. Second thing was I was quite happy that you were calm and composed. You could catch the hints of the examiners. Many examiners might be neutral. They might not give you much of hints. So that is when the difficulty. But still, if you're composed, at least if you get a very hinting examiner, if you're able to catch the hints, they would be more than happy as long as you're able to keep your mind open and able to catch the points, what they want from you. Okay. Yes, so I'll just, sir, can you share? It's not being shared, sir.
Ma'am, was it implantable cardioverter defibrillator? Was that something I missed?
No. Regarding, you're talking about the chronic spinal cord injury patient?
Yes, ma'am, because he had...
You mentioned about one is autonomic dysreflexia, right? So how do these patients present in the history? They give a history of severe headache, okay, or flushiness, facial flushing, nasal stuffiness, tachycardia, okay, and present with other hypertensive induced sequelae in the end organ damages, which could be from the head to toe, a perioperative, a previous stroke if necessary also. It could be a cardiac injury. Okay, so you have to highlight all these histories, which is very important. Because when you're talking about a perioperative autonomic dysreflexia, these patients can have any such insult during the procedure. Okay, and hence prior to your waking up the patient, you have to ensure all this is fine if you have had an autonomic dysreflexia event.
Yes, ma'am. Okay.
Got it?
Yes,
Yeah,
ma'am.
so this is a short preparation which I have done. That is, we discussed about what's the diagnosis, what are your concerns, thyroid storm. Okay, there is a very famous mnemonic, it's hot hormonal heart convulsions. Okay, so if you remember these 4 things, hot means you need to treat the temperature, which you missed on it. You need to manage the temperature as well. So for that, what would you do? Rapid cooling, paracetamol infusion if needed. Okay, a dose of paracetamol. If further needed, then you need to give washing. Okay, you have to give NG ice wash. Okay, or a bladder wash, or axillary packing, ice packing. These are the various methods where you can do the cooling measures. Okay, then you have to treat the hormonal, which is your thyroid. So there you rightly made the same mistake which I was expecting you to do, which is giving leukocytin prior to the administration of leukocytin, prior to administering the drugs which block the synthesis, because this leukocytin itself will be taken up in the synthesis.
Yes, sir.
Yeah, so that's why you should follow that sequence. This is what the examiners are waiting for you to make commit on. Okay, then second thing is with regards to the heart. Third, that is heart. Heart, you have to treat drugs, as you rightly mentioned, about the beta blockers. So that's fair enough. Okay, then going further down, the convulsions. The patient can even have convulsions. So you might have to keep your anti-epileptic drugs ready.
Anti-epileptics, okay.
Yes. So in this patient, the additional monitoring which I was expecting from you was, one is, yes, temperature monitoring, invasive blood pressure monitoring, NMT monitoring. Okay, and of course, you need pads attached to the patient. So if needed, you have to give a cardioversion or defibrillation as and when required. Okay, then the very important what I was expecting from you was, this is a spinal cord surgery. So you might need to have your evoke potentials attached as well.
Yes, okay.
Yeah, so motor evoke potential or sensory, somatosensory evoke potentials, depending upon the level and depending upon the practice in your setup, whatever, you can go ahead with that as well. So once you are told that, then I would have taken you into the various anesthetic
factors, the agents, how they affect the...
Exactly. So I would have taken your Viva to that direction about how the anesthetic agents affect the monitoring. Okay, so that was one of the important monitoring concerns. Then you spoke about the difficult airway well enough, the fiber optic, the video laryngoscope is all fine. Okay, and then I took you to a scenario wherein the patient had a perioperative thyroid storm with atrial fibrillation. So that's when you realize that you didn't attach the defib pads, right? So that was fair enough. With regards to the post-op plan, you mentioned about one is airway. Second is about the respiratory compromise, for which this patient might not be able to be extubatable. Third important is he's already in a thyrotoxic state. Okay, and he has had important cardiovascular events perioperative. So you would not want to extubate a patient in an unoptimized state.
Yes, sir.
Right? So, and also being an airway surgery. So there are multiple reasons for which you would choose to have an elective postoperative mechanical ventilation in this particular patient. Got it? Apart from your airway, the cardiorespiratory status preoperatively, his current, and he was cardioverted twice already in the ambulance. Intra also he had an atrial fibrillation. He's still in a thyroid storm state. Right? So these are all the indicators wherein you would want to keep, and you rightly mentioned, it's a high cervical cord injury. So the chances of weaning is going to be difficult. So you might have to plan for a tracheostomy. But at this stage, if you do a tracheostomy, you're going to aggravate the release of thyroid hormones further. Already the surgery being, exactly, already the surgery being a neck surgery, the cervical spine, you're going to have a lot of handling. So there is a possibility of perioperative thyroid storm already. And you want to do a direct tracheostomy, you want to further aggravate the situation. So you would not want to plan for a tracheostomy right now.
Understood.
Got it? So this is the further things they can ask. Then anti-thyroid drugs, which I briefly touched upon it. Then we spoke about the thyroid. They can ask you about the thyroid physiology also. They can probably touch you on spinal cord blood supply. Then if the same patient presents later on date for a chronic spinal cord injury, what are the important concerns? So we spoke majorly about autonomic dysreflexia, but you have to have the various concerns from head to toe. Right? So the airway concerns, okay, then they can have sleep apnea as well. The central pharyngeal, the central musculature can be affected, bulbar palsy can be there, okay, or they can have, they can have gastroparesis, so the chance of regurgitation, aspiration, okay, then cardiorespiratory status, because cardiovascular status because of the autonomic dysreflexia, what is the neurological status, and then what were the other triggers I was expecting from this? Any kind of bladder distension by itself can trigger autonomic.
Okay.
Yeah?
Yeah, true.
Okay, so these are the important points, and we had a short discussion on this topic as well. So overall, I would say you were fair enough to start with, okay, but as you progressed, there were certain points when you got stuck, I think you slowly lost your confidence. I don't want you to do that, because this is such an examination wherein you'll be given a lot of questions. So even if you miss on a couple of questions in between, do not lose the tempo. As long as you're able to, attempt as many questions as possible, which itself is a sign that, you're doing quite well. You get that? So I want you to increase your speed a little more on your confidence, and do not lose the tempo. Suppose you're missing on one or two questions.
Okay. Thank you.
that what Dikshita has just told you is the technique of how not to lose even a single mark. Yes, from her own experience, she can tell you exactly how not to lose even a single mark. Because she has scored 100% in this exam. So we take every word of it very seriously, what she's just mentioned.
Thank you, sir. Thank you, sir, for that. Yeah, that's very true. In my own experience, I mean, I'm happy to say this at the same time, because my first table was on one lung ventilation, which was my all-time difficult topic. And as soon as I got that, I was like, okay. I mean, as soon as I read the question itself, I was haywire already. But I tried to somehow keep myself composed. And though they asked a couple of questions on it, I was trying to attempt a bit on it. But in between, there were questions wherein I could not answer well as well, which I myself could figure it out quite well, that the examiner was not convinced with me. But I was continuously answering further questions. I tried to keep my tempo. So though at the end of the examination, I felt that I didn't answer quite a lot of questions, but ultimately when I got my result, I was kind of shocked. So this is what I realized from my own experience. I mean, it is, yeah, even if you miss on a couple of questions, and even if you think it is majorly wrong, I mean, you've not answered it, it's a big mistake. Do not lose your tempo and go ahead further with the exam.
Absolutely. Great. Fantastic session. I think you guys are enjoying the flow of the session, where we finally managed to go with the full steam ahead. Who would like to go for the next Viva? I think one of the female candidates, it was Dr. Aparna, isn't it?
Nirupma, sir.
Dr. Nirupma, yes. Please go ahead, Dr. Nirupma. I will share the scenario.
Hi, Dr. Nirupma. How are you?
Hi. I'm fine, but not able to prepare much. So I'm forgetting the other things. Let me try this.
Don't worry, you'll be fine.
This will give you the exact momentum, Dr. Nirupma. The session.
Yeah, that is why I joined this. Thank you.
Yeah.
Okay.
So I'll read out the question for you. You have a 32-year-old female patient who's 36 weeks pregnant, and she's a known case of multiple sclerosis. She is diagnosed as a case of placenta accreta spectrum as well, in addition to her multiple sclerosis. So she has come to you for a planned elective cesarean section for her pre-anesthetic evaluation.
Okay.
So I give you 1 minute's time, you can prepare. Can you start now?
Yeah. Yes, you can start.
Yes. So tell me, Dr. Nirupma, what are your concerns and how would you go about in a pre-anesthetic evaluation?
In this pre-anesthetic evaluation, I will ask her about like the issues in this case are one is multiple sclerosis, second is placenta accreta, third is this is a case with 2 lives involved, the child and the mother. So there are 3 issues. So I will try to evaluate on these based on this. About the multiple sclerosis, I will ask about a history of remissions and what the medication she's on. And is there any episode during the pregnancy, although the episodes are less during the pregnancy? And
why do you think the episodes are less during the pregnancy? So to start with, what is multiple sclerosis?
This is autoimmune disease.
Okay.
And because of this antibodies, there are some multiple fibrosis in the brain, the neuronal tissues. And because of that, there will be decrease in the neuronal activities.
So the antibodies are formed against what?
Antibodies are formed against the myelin sheath.
Okay. Okay.
So demyelination happens in these cases.
Okay.
And that is why that is the concern.
Okay.
So because of this, I have to ask about the history and also the medication. She might be on steroids as well as methotrexate or something else, some other or immune suppressants.
Yes.
And then about the gestation,
Mhm.
and there is a placenta accreta diagnosed. So the gestational age may not be term. The patient may not be term. She is
Okay.
32-year-old, but with term pregnancy in this case. So
Yeah.
it's
Okay.
any history of bleeding before.
You
does it-
mentioned that there's multiple sclerosis in pregnancy. What did you just say? I mean, does it worsen in pregnancy?
No, it doesn't worsen.
Why so?
Because it has two types of because it is not usually the immunity is of two types, the cell mediated and another one is hormonal mediated. So because of the hormonal status, it doesn't aggravate
Okay.
during pregnancy.
Okay. Yeah.
But there are chances of aggravation after the delivery. This so
Okay.
that was my concern.
Okay. So what are the various types of multiple sclerosis?
I just forgot that. The progressive, there is multiple sclerosis with progression, and another one is with remission.
No issues.
Yes,
No issues. So one concern was your multiple sclerosis. Second was this placenta accreta spectrum. So what is this placenta accreta spectrum?
Placenta accretus, in this, the placenta invaginates inside the uterus. So when they try to remove it, there is a lot of bleeding, and it may require even the hysterectomy.
Okay.
So we need to prepare the gynecologists. They are prepared with the extra help from the surgeon sides. We may need to ask for interventional radiologists to be standby in case of any bleeding or postpartum hemorrhage occurs in this case. And we
Okay.
need
So
to
any other pre-anesthetic evaluation you want to do? We will go to the management, but any other pre-anesthetic evaluation?
In this, the hemoglobin is very important for the patient,
Okay.
preoperative.
Yes. Anything else?
So I have to ask for the blood has to be cross-matched and kept ready. That is,
Okay.
and
Okay.
the interventional radiologist, I told you beforehand. Also, the pediatricians, they have to be ready to receive the baby. Because this is
So I am happy with this multidisciplinary team which you want to keep it prepared. So that's fine. But my question is, what else are your important things which you want to look for in the patient during your pre-anesthetic evaluation? Because right now the patient is in the PAC clinic.
Yes, I want to assess the airway, the spinal cord, the spine, as well as if there is any, because my concern is I can go ahead with the general anesthesia, but we can use spinal anesthesia also in this, or epidural anesthesia in these cases.
Okay.
Because there are studies that we can go ahead with regional also in these cases.
What are the concerns with regional?
Concerns with the regional is because of the demyelination, it may aggravate the situation of multiple sclerosis, and the neurological deficit can be more. That is, and the concentration of the drug that can damage the neuronal tissue.
So which regional do you want to plan in this patient?
I would like to go for epidural anesthesia with the low doses of progressive low doses.
Okay.
Of anesthetic drugs.
Okay, fine. Anything else? So what are your concerns? Suppose I say that this patient denies for regional anesthesia and she wants general anesthesia. So what are your concerns in this particular patient with general anesthesia?
In case of general anesthesia, I want to check for the airway. Is it a difficult airway?
Okay.
Even if it is not apparently difficult, it can be an anticipated difficult airway.
Yes.
The gastric stasis can be there. So he needs acid prophylaxis. As well as I want the difficult airway cart ready by my side.
So in any obstetric patient, you expect delayed gastric prokinesis. Do you think it's of more concern in this particular patient?
Yes, it can. Yeah.
Why so?
Because of multiple sclerosis, there can be autonomic neuropathy also.
Okay. Anything else?
I'm sorry for this.
No problem. Go ahead. So what are your other concerns with general anesthesia?
With general anesthesia, since there can be more of depression after giving the general anesthetics. So post-operative care, we need to be more vigilant.
Okay.
And it concerns for the child, the baby, when it is delivered, they may be hyporeflexic. So pediatrician need to be informed prehand.
Okay. Any of your concerns with your intraoperative period?
Intraoperative period, the temperature we have to maintain. It should not be very high, because that can also aggravate the situation of multiple sclerosis. Okay. We have to maintain it in a normothermia.
Okay.
And we have to avoid hypoxia, hypercardia, and hypertension.
Okay. Any concerns with your muscle relaxant?
Muscle relaxants, yes, the non-depolarizing muscle relaxants, they can be used, but their doses should be reduced because they are very sensitive.
Very sensitive. Okay. Yeah. Anything else?
No, nothing much.
Okay, fine. Okay, so this patient is taken up for the surgery, and because it's a placenta accreta. What is placenta accreta spectrum?
Placenta accreta spectrum in this in the first state, there is only invagination to the first layer of the uterus. Then it goes to the myometrium, and then it goes to the it crosses the placenta, and it crosses the uterus and can go to the extrauterine structures also.
Do you have a term for it? The last one you mentioned. Okay, no problem. So suppose we consider that it has invaded the entire uterus and it is, already on the serosa. Okay, so what the surgeons, the obstetricians have planned for a perioperative hysterectomy as well. Okay, so what are your important concerns now? What do you want to prepare now?
I need to have blood in my hand.
Okay.
Then in case it's still after hysterectomy, it usually stops. But massive blood transfusion protocol, I have to raise the alarm for that.
Okay.
As well as I will need another help. More hands will be needed.
Okay.
So I will ask for that.
Okay.
And hematologist help may be needed because of the blood products. Various blood products may be required.
Okay. So what are the additional monitoring or additional equipment would you want in this particular patient?
In this case, we need an arterial blood pressure.
Okay.
To give us beat to beat variability, and there will be massive loss. So we will be needing that. Plus the rapid infusion for that the infusion need pressure bags to infuse it rapidly. Then the for the temperature regulation of the blood and the IV fluids, because there will be a lot of fluid and blood going. So we need to maintain that temperature.
Okay.
Also, we need to have a population profile checking intraoperatively, if it is possible, and blood gas analysis.
Okay. So that's with regards to the monitoring and the equipment. So what are the drugs you want to keep ready?
I might need the inotropes if there is any fall in blood pressure, and tranexamic acid that is required in this case. I will give it prophylactically, and
yes.
Okay.
What are the 4 T's of PPH?
This is tissue, and one is tissue. This is other is thrombin.
Yes.
Then this tissue thrombin temperature is not there.
Okay. Okay. So when you're managing this patient, she's already started having an hemorrhage, right? Intraoperative hemorrhage, which might progress to PPH as well. So the surgeons are trying to do what are the maneuvers the surgeons can do now?
Surgeons can do this manual compression. They can give.
Okay.
And then there can be balloon can be put from inside, and they can help in preventing the blood loss. And then they can cord the clamps.
Okay.
They can clamp the arteries, and later on they can go for hysterectomy.
Okay. Anything else? Any uterine preserving procedures?
That is the interventional radiologist. They can do the thrombosis of the artery.
Thrombosis of the artery.
Uterine artery can be thrombosed.
Okay, fine. Okay, fine. Let's stop the Viva here.
This was really bad.
Oh. I mean, I was happy that I'm sure you have attended our previous Vivas. So I was happy that many of the points which we discussed earlier, I think we discussed this topic also earlier. So you could highlight on them, but certain points, yes, definitely, which were vital, you did miss. It's okay. We will discuss that now. Okay. Tanisha, can you please display the feedback? the points to be discussed? If he's not there, I will try to share my screen once again. Just give me a minute. Not too sure, it's not able to share the screen. Just give me a minute. Okay, otherwise, anyways, the points I had written was, as you all know, in this particular patient, the concerns were, one is the patient has placenta accreta spectrum, right? The second was the patient is a case of multiple sclerosis as well. Then we have a scenario of major obstetric hemorrhage with postpartum hemorrhage. So what are the various preparation you might need in this particular patient? What is your plan for anesthesia? Okay, and this management would include your conservative management, surgical management, pharmacological management, and interventional radiology management. Yeah, sir is back. Okay, followed by the blood management. I mean, you need to arrange for the blood, you need to inform the blood bank, you might have to activate the major transfusion protocol. And as you rightly mentioned, TEG and rapid infusers, cell salvage technique also if needed. Okay, so these are the various things which can be discussed in this particular topic. So to start with placenta accreta spectrum, she mentioned about the various definitions. It was accreta, increta, and percreta, which several participants had posted in the chat box. Okay, so in the history, if in the pre-anesthetic evaluation itself, I would want you to review what is her current placenta accreta spectrum status, whether she's an accreta, increta, or percreta. This shows, like, I mean, if you're clinically practicing in such a patient and you have such a patient, you would obviously want to know what is the status of invasion. They would have definitely done an MRI, which should show the current invasion status and what are you anticipating. Okay, so you have to know what is the current status of her placenta accreta spectrum. That's one thing. And hence you'll have to plan your anesthesia and your post-op plan, your multidisciplinary team. I was happy she did mention about the multidisciplinary team right from the beginning. So that way it was carried forward. The second thing with regards to multiple sclerosis, yes, it's an autoimmune disease which involves your myelin sheath, which is a demyelinating disorder. Okay, so this by itself can cause various manifestations. So you'll have to evaluate her overall. So a couple of participants had they had put in the chat box regarding her vision status. Yes, regarding her overall head-to-toe examination is important. Neurological status is important. Does she have a bulbar involvement also? Because she might be more prone for regurgitation. She might be a case of difficult airway. As such an obstetric patient, yes, she rightly highlighted all these things points. But the medications she told about, and what are more important is they could also have some spasticities for which they can be on baclofen, and hence the importance of muscle relaxants and NMT monitoring during the intraoperative period. So that is what I was trying to look forward, apart from the other concerns for general anesthesia in this particular patient. With regards to the regional, there is a controversy between whether spinal can be given or not, but the earlier said proposed theory is that because of the direct deposition of the drug in the subarachnoid space on the neurons which are already demyelinated of the concentration required, this can further aggravate the injury, they say. So the preferred previously proposed is epidural. There are still certain controversies going on with regards to spinal and epidural, but still the safer answer would be, as she rightly mentioned, to go for an epidural. But in this case, who's planned for an major obstetric just with an epidural, I do not know how far we could go for the procedure as such. So you might have to, if feasible, if the epidural has taken up well, it's fair enough. Otherwise, you might have to combine with general anesthesia in this particular patient. Okay, and here again, with regards to the various monitoring and the preparation, she mentioned almost all the points. Okay, and the blood gas analysis, the TEG analysis, accordingly, you'll have to get the blood and blood products. So that is all fair enough. With regards to the management, that is where you slightly missed quite a lot. With regards to the conservative management, the surgical management, you were mentioning about the compression, the balloon tamponade. There are other methods also, which is the Belin sutures they can do. Okay, they can do the uterine artery. Yes, later on you did probe and you get it about the uterine artery ligation. And finally, if needed, a hysterectomy. Some people, they even, if it is not completely invading, they just try to remove the placenta as far as possible. Okay, if they're able to, if it is just an accreta. Okay, and try to get in control of the bleeding situation. Okay, and of course, here they can take you into the PPH definitions. What is it after a normal vaginal delivery beyond 500 ml, beyond 1 liter in the case of cesarean section? That is one thing. Then with regards to the pharmacological, you mentioned about tranexamic acid, but what about the other drugs? That's when you could not answer, I gave you another hint. What are the 4 T's? tissue, tone, trauma, and thrombin, right? So you missed on the tone and the trauma. So tone. So if you had told that tone, I'm sure you would have remembered what are the drugs I'm expecting out of you now, the uterotonics, right? So here the role of uterotonics, the carbitocin, the prostaglandins, carbaperos, all these are very important over here. So this is what I was expecting over here with regards to the pharmacological management. Then with regards to surgical, we already spoke, and she very nicely highlighted the role of interventional radiology. Wherever you have a question wherein there can be a role of interventional radiology, please do mention about it, because that is the conserving measure which can be done without with a less invasive technique and more better results. Okay, so they can even go for the Riboa technique, the endovascular balloon occlusion of the aorta. They can go ahead with that technique also with the infrarenal. So these are the various techniques, and it is more of embolization, doctor. Rather than saying as thrombosis, you would say it as embolization of the particular artery. Okay,
yes, right.
So so and then once you are told intervention, they can even take you into the various implications of a non-operating room anesthesia. So these are the various sectors they can take your Viva to. But overall, it was fair enough. But yes, certain important vital things were missed. So if you can catch up on that, that'd be great.
Yeah, thank you. Thanks a lot.
Thank you. Nancy, are you there? I'm not too sure if sir is there.
He is there.
Okay. Dr. Amrita has already joined.
I think sir was asking for a break. Let me call him.
Okay, you were saying about the marks and all that.
Yeah.
Yeah.
What marks, doctor? Sorry.
You were saying that the candidates will be marked on the basis of the Viva, so that we can have an idea how the marks are given.
You mean in this session?
Yeah, maybe this is 1 minute, whatever we have gathered, maybe about that.
Okay. I mean, generally we would rather want Daniel is here. Yeah. So what we had actually decided was to give a feedback and highlight on the areas, not only the factual part, but where can you improve on the way of delivering the answers. That was the main focus of this particular session. And with the minimal factual discussion as well, the various teaching-based discussions, which we usually do. But of course, the main target for this masterclass was that to highlight on how you can take your Viva through the examiner. That's one thing. Second thing is how you can deliver the question, the answers in a more of a clinical scenario-based situation, rather than just answering in a factual way. How do you go about in your daily scenario, so that how much you're composed and you can answer on this. And you have to be able to catch the hints and follow a particular structure in each answer. That is, as we've already discussed, we have discussed in the previous sessions, if it is a critical scenario, you call for the help, do the general management of ABCD, then you go for the specific management, and then the scenario-based management, post-operative care. So you follow a particular structure in each question. Suppose, like just in the previous two Vivas, which we had in my topics, you make a flowchart of the important concerns in that particular patient, so that you can see that flowchart all throughout when you're answering, and you don't miss on any of the points pre, intra, and post-operative.
Right.
Yeah.
Okay, thanks.
And following on Dishita's point, this is a taster session. The idea is to make you aware of the scale of the Viva, to understand that one session is never going to be enough to prepare you for it. But at least this session will sensitize you, make you aware of how you need to time yourself, what kind of preparation you need to build up around your Viva. In the past, we've seen people have underestimated Vivas, and they've only given 2 months or sometimes even less, and thinking that should be enough. Probably in MCQs it is, but not in Vivas. It's a new skill you're developing. It's not just knowledge; it's a completely new skill that and it's not a skill that you've had throughout your life. It's something very new to be able to confront an examiner where you're being cross-questioned and all that. So it's just to give you the scale of the enormity of the time and efforts and resources that you have to put in together. Great. So I think it's been a long session so far. I think the gray cells have turned white by now. I think you guys need a little bit of a coffee to switch them back again. So have a little 5 minutes break, and let's make it a short break. We'll come back in 5 minutes time. Okay. Thank you. So welcome back to the post tea time. We're not going to be going for very long now. It's only an hour from now. And Dr. Amrita is going to be taking the next session. If you have not seen her in the video recordings or not faced her, I will introduce her to you. She is one of our distinguished faculty, one of the duos, Dr. Dikshit and Dr. Amrita, based in Varanasi. in the Institute of Medical Sciences. She's an associate professor there, and she is also involved in lots of teachings and courses in regional anesthesia, pediatric anesthesia. She has many hats on. So today her hat is about Edaic 2 vivas. So I will hand over to Dr. Amrita, and before that, I hand over to her. Can I please have the next 2 volunteers for the viva, please? Okay, Dr. Kadapa has put his hand up, and anyone else who wants to do the second volunteer? Okay, start with Dr. Kadapa. I'm sure someone will follow soon. Over to you, Dr.
So you can make me the host, so I can share my questions on the slides.
Okay. Yes, you can share now.
Okay.
I will make the host as well.
So can you see my screen?
Yeah.
Okay. So you have a 81-year-old man with a history of MI and stroke 5 years ago, and the patient is on rivaroxaban 10 mg OD and clopidogrel 75 mg OD, and the last dose was taken 12 hours ago. He met with an accident in the bathroom, and now he has reported to the emergency with severe pain and suspected hip fracture. You have exactly 1 minute from now.
Pardon?
You have exactly 1 minute from now. This is your opening question.
Okay.
Okay. So we'll start your viva. Did you read the
Okay.
question?
Yeah, ma'am.
Okay.
Yeah,
So,
yeah, my plan will be according to history and clinical.
Let me ask the question.
Okay.
Okay. So what are your various pain management options that you can provide right straight away to the patient on arrival?
Pain management is multimodal analgesia technique. We'll have so many, like World Health Organization has provided a ladder. So we'll include NSAIDs for weak pain. For moderate pain, we'll introduce mild opiates. For severe pain, we will use severe opioids. And for intolerable pain, we are going for neuraxial blockades. Always pain management is multimodal analgesia. All these techniques can be employed, or we can use patient-controlled analgesia pumps to him or nerve blocks.
Okay. So my question was, the patient is in ED, emergency department, and the patient has just arrived. Will you like to give a spinal to a patient who is in ED?
No.
Okay. So would you like to change your answer?
Yeah, it will be like oral or IV analgesic and with patient-controlled pumps. That
Are
can
you
be.
aware of any regional anesthesia, analgesia technique which you can provide instant pain relief to this patient now?
Pardon, ma'am?
Are you aware of any regional analgesia technique which can provide pain relief to this patient?
Blocks, ma'am, like femoral nerve block. That can be done to relieve the pain.
Any other block?
Uprotor nerve block, femoral nerve block. Lateral cutaneous nerve block, lateral cutaneous of thigh. 3-in-1 block.
So this patient is on platelet and anticoagulant. So would you like to
Your
give?
voice is cutting.
The patient is on both anticoagulant and on a platelet, antiplatelet drug. Would you like to give a femoral, LFCN and obturator, whatever you have mentioned?
No, ma'am, he's not. I won't give because it should be stopped. Oral anticoagulant should be stopped for 72 hours.
Okay, fine. So can you tell me how are you going for the clinical evaluation of the patient or a brief PSC? How you're going to do that?
I'm going to ask the history. When was the MI and what medication he is on? I'm to assess the drugs he is on, and when was the stroke? When is there any repeated attacks? Is there any focal neurological deficit, transient ischemic attack? What is the medication he is on? I'm going to involve multidisciplinary approach with cardiologist and neurologist and orthopedician. And I'm going to check the ECG because he's an history of MI, recent ECG, echocardiogram. I'm going to check and PSC and his coagulation profile because he's an antiplatelets and oral and his coagulation, basic hemogram, renal function. Left is because of the drugs that I'll be evaluating routinely. That is PAC.
Okay. So suppose this patient asks you the question that what is the risk factor of my being ending up with a mortality. Are you aware of any scoring system that is used in a patient who has a history of a cardiac history?
Yeah, least revive cardiac risk index.
Can you tell me what are the parameters of
Yeah,
revised
major abdominal surgery or intraperitoneal surgery, previous history of stroke, previous history of MI, previous history increase in serum creatinine more than 2 milligrams of
Very good.
history of diabetes mellitus.
Okay. So how many parameters you counted on?
7 parameters. If it is more than 2 parameters, risk of mortality will be 11%.
So what is for this patient?
It will be more stroke and MI history 2 is there. So 11% chance of mortality.
Okay, fine. So the next question comes, will you let the patient get operated immediately or you can wait?
We'll take the X-ray at least to see is there any fracture or not. Is there just
That's a hip fracture. That is a hip fracture.
hip fracture? Okay.
Yeah.
Hip fracture, because long standing, we can't wait. Although he's on oral anticoagulants, but fractures to be stabilized as early as possible. I would like to go with the neutralizing agents for rivaroxaban, with like Andexa, is there. And for clopidogrel, I'll arrange the FFPs, all these things.
FFP?
No. Blood loss will be there, so I'll arrange the blood products and clopidogrel also, because stabilization is important in hip fracture cases.
Okay. So you wish to do immediately or you wish to take some hours to go? Means, is there any like guideline, or I can say the reason for delaying surgery? And if you're delaying surgery, up to what hour it is recommended to delay? And what is the advantage of delaying if at all you're planning to delay the surgery? Are you aware of any such guidelines? Yeah? What happened? Dr. Sanjeeva, can you please mute yourself? No issues. We are on a serious stuff. That's why I just told. Yeah. Back to Dr. Kadapa. Yes. So can you tell me, like, what is any guideline there where you can delay the surgery? Okay. Or
surgeries can be divided into urgency, emergency. If it is an
what kind of surgery is this? Emergency, urgency?
It is urgency surgery, but not an emergency. So we have some time, so that up to 4 to 6 hours we can stabilize and do.
Okay. Fine. So what are the anesthetic consideration for this case? What are the consideration you have in your mind for while dealing with this case?
Major, he is having MI history and stroke. So intra chance of MI and stroke are high. So that will be, so intra I'll be aware of the ECG monitoring and everything. In ECG, routine monitoring I'll keep. And urine monitoring is also important because of chance of fat embolism syndrome, all these things. So that will be checking ETCO to everything I'll keep.
Okay, Dr. Kadapa, just let me repeat the question. My question is, what are the anesthetic considerations or challenges that is coming in your mind for this case?
Whether I have to go for regional or GA.
Okay.
That is the main concern. Okay. Because it's an emergency surgery, I'll prefer to go with GA.
Okay. So one consideration is whether you wish to go for regional or GA. Next consideration.
Whether intra risk of MI stroke will be there or not.
Next.
And orthopedical related complications.
Next.
That's it.
Fine. So as you mentioned about the confusion between to go for a GA or a regional, how it is decided? Like, what is your preference for this case? Would you like to go for a GA or you would like to go for a regional?
For this patient, it is GA is preferred because he is on oral anticoagulants and antiplatelets. So if a regional block is given, so chance of spinal hematoma will be there.
Okay, fine. So the last dose of the rivaroxaban that was given was 12 hours prior, if you remember, right? So if I delay the surgery for 12 more hours, I wait for 12 more hours, can I do under regional now?
No, clopidogrel has been stopped for 5 days. Rivaroxaban has stopped for at least 72 hours, 3 days.
Okay. So can you tell me the dose that is being given to the patient, 10 mg, I repeat once more, is a low dose or is a high dose?
Low dose 10 mg.
So what is the recommendation for low dose? As you mentioned that the patient, the rivaroxaban can be reversed. So is the dose same for the reversal for both low dose and high dose, or it is different? Or you're not aware of it?
It is different, but I'm not exactly.
Fine. Suppose in your setup, you don't find the antagonist. Is there any other way to reverse the effect of rivaroxaban?
No idea.
Have you heard about the term platelet PCC concentrate?
Prothrombin complex concentrate. It will provide 2, 7, 9, 10 clotting factors.
Okay, so for this patient, would you like to go for a PCC3 or PCC4?
PCC4.
PCC4, fine. So my next question is, can you please classify the direct anticoagulants agents?
Direct thrombin inhibitor, factor 10A inhibitors. The thrombin inhibitors are dabigatran. 10A inhibitors are rivaroxaban, epizipan, endoziban.
Fine. So what is the antidote for dabigatran?
Idamalizumab.
Idalimumab.
Idamalizumab.
Okay. Have you heard about bridging therapy?
Yeah, ma'am.
What is a bridging therapy?
We can bridge with other anticoagulants.
So when it is recommended?
If it is an high risk surgery, for suppose warfarin is bridging with heparin.
Fine. So my question is, who are the patient who need a bridging therapy?
If no idea.
Okay. Suppose the patient has a like just for a discussion, what do you think? The patient has a thrombotic risk, the patient has a bleeding risk.
There's a bleeding risk.
I will come to one by one. Don't worry, I will drill everyone. It's my favorite work actually. So you mentioned, so there are two things when you consider whether to go for a bridging or not, right? Thrombotic risk or a bleeding risk. So what is the point which has to be balanced more if you want to continue with the bridging therapy?
Thrombotic risk has to be balanced.
Okay. So are you aware of anything, any criteria or something? Who are the patient who are high thrombotic risk?
Patient who are immobilizing patient for long duration surgery patients, obesity patients.
So I'm asking about high risk thrombotic patients. You're mentioning the risk factor for thromboembolism. I'm asking who are the patient who are at risk for high thrombotic patients in which you have to go with the thrombotic agent.
Pregnant patient or who was on OC pills.
Okay. And what about bleeding? Is there again any criteria to know who are the patient who is at risk of more bleeding, or it depends just on the type of the surgery? Or both?
No idea.
Okay, no issues. So what is your plan for this patient? So finally, are you going for GA or regional?
GA.
You're going to go for GA, fine. So when you are planning to restart the drug?
Post surgery, if the drains are okay, not bleeding too much, so you can start 24 hours after the surgery.
Earliest is 24 hours. This is what you mean?
Yeah.
Okay, fine. So okay, because you missed few of the question, I will ask you. Okay. What is the post-operative pain management for this patient?
Yeah, there's multimodal approach. I said like a patient control analgesia pumps and nerve blocks, or fentanyl patch or morphine patch.
Okay, fine.
Or
So
nerve
I'll
blocks.
stop you here. How you felt about yourself? I will stop your Viva here. How you felt about yourself? You're so happy that I stopped you here.
Just I didn't practice just for routine.
It's okay. We are here to just this is as sir and everyone has told before me. This is just a test session so as to make you aware of how the exam goes. We are not here to judge you. We are not here to comment or intimidate you. We just want you to analyze the level of the exam it goes. Definitely, you would have encountered such scenario, and the exam primarily focus on your decision making in such cases. There is no right or wrong answer. It is basically what you know, how with the depth you understand the gravity of the situation, and how you are taking a decision. That is what I was testing your capacity. Okay. So I would say, because I know it was it was not in fact a tough topic. It's a very important topic, and this topic usually they ask in exam. Okay. And about hip fracture, recently 2-3 important articles that Association of Anesthesia of Great Britain, Ireland, they generally ask from those BJA. So they have come up with new guidelines also. So you need to be updated about such means new practices also. So what has happened, you are going through your podcast and all for clinicals, they have not updated books, right? So if you go for a hip fracture, what they write is now things have changed a lot. So you have to basically this topic is entirely to make you aware that world is revolving around in a different plane. You need to keep yourself revolving along with it rather than just going through your routine like years together prescribed books. Okay, fine. So I will just give you the quick feedback of what you missed and what you should have told. Just one second. So can you see my screen?
Yeah.
So for a few people who missed the question, so this was an 81-year-old man who had a history of MI and stroke 5 years ago and was on rivaroxaban and clopidogrel, and the last dose he received at 12 hours prior to coming to the ED, and he had a fall in the bathroom. So now he's in severe pain and there's a suspected hip fracture. So what answer I was asking, what are the on-arrival blocks? So whenever we ask you a question, always go with a classification. You just jumped into one portion that you were quite sure about was a WHO 4-ladder pattern. But before that, whenever you answer in 4 different steps. One is pharmacological, non-pharmacological, interventional. Okay?
Okay.
If you talk about pharmacological, NSAIDs is better avoided in an 81-year-old people. Okay, rather you can go for a paracetamol, opioids, and if needed, opioids, as you mentioned. Second is interventional. It is very important to, I was confusing you here, though patient was on antiplatelet and anticoagulation, you can always go for a fascia iliaca, that is suprainguinal fascia iliaca, and a femoral nerve block. Okay. Those who have answered PENG is a wrong answer. PENG is a deeper block. Deeper block should not be given in a patient who is on anticoagulation. So recently, Prospect 2024 has come for hip fracture, and they have recommended paracetamol COX-2 inhibitors, opioids as a reserve for rescue analgesia, regional anesthesia, single shot FNB, including 3-in-1 block, or a single shot FICB. No catheter is needed. Okay. So if you go by the guideline, and European Society endorsed Prospect guideline because it is made by the Association of the Surgeon and the Anesthetist. So you should be aware of these 2 blocks, and these are the blocks which are the on-arrival blocks. Fine. LFCN, which you are getting confused, and obturator are not on-arrival blocks. Better you go for a single shot femoral or suprainguinal fascial block. Next, I was asking, then it comes to your, what are the non-pharmacological therapy? It is immediate immobilization of the patient. And you can always talk about non-pharmacological reassurance, ice therapy, music therapy, hydrotherapy. This may not carry any mark. But if you talk about a non-pharmacological with a classification, the examiner is very well convinced that you are going with a structural approach. Okay? Can you please mute yourself?
I will check.
Dr. Sanjeeva, again you have unmute yourself.
You may mute him yourself. You're the host, Amrita. Or I'll reclaim the host.
But sir, how can I share my slide?
You will still share. Sharing is activated.
Then it came to clinical evaluation. So I was asking, so whenever you get a trauma patient, it is just I mentioned it's a hip fracture. You don't know what happened. So always think in a multiple line. When the patient, what is the mechanism, like how you do in ATLS? What is the mechanism of injury? What is it, whether it is the road traffic, what is why the patient fell? Because he had already history of a CV and MI. Was it another, what was the sequence that followed this event? So you should always have this in your mind. And you have correctly mentioned you should know about the cardiac and neurological status. What was his fasting medication? Like we do the ample history for any patient who comes for an emergency. You didn't mention anything on ample. Okay. Then whenever, just imagine, whenever I ask you, what is the clinical evaluation? How do you rate your question? Always we answer history, physical examination, investigation. Again, it's a structural approach. In history, tell 3-4 points. In physical examination, you will go for a vital signs because it's a trauma case. Always see if hemodynamically stable, unstable. Go for a cardiovascular if any sign of active MI is there, which has led to this situation. Neurological examination, if there is a rebleeding, restroke chances. Okay. And then you go for an overall head-to-toe examination, the same ABCD approach which you follow for any trauma patient. Then comes investigation, as you have clearly mentioned, but here, one of the most important thing is RFT. Because renal function test is very important when you talk about the rivaroxaban clearance. Apart from coagulation profile, okay? Rest, blood grouping, cross-matching, all this thing you have to talk. Then components of RCRI. You mentioned 5 components and you numbered 7 components. So the trick of the exam is when you're not sure of anything, don't tell random numbers. At least tell, I can remember 5 points. I'm not sure how much I'm missing. Okay. But most of the points you told correctly. High risk surgery, of history of IHD, of CHD, of CVA, IDDDM, and serum creatinine more than 2. So for this, it comes in 2 points. So here it comes to 1 to 6% of the MACE. And this has been asked in the last month exam about RCRI. LEAS was previously practiced and now it has become revised cardiac risk index. AHA 2024 has come up with again this update, and they have endorsed 4 scoring, of which RCRI has still remained the same, and RCRI was accepted by the European board. So you always have to remember ASA, RCRI, there are few scorings which you cannot afford to miss. Of them, one is RCRI. Then come anesthetic management. So you mentioned about cardiovascular anticoagulation. So since the patient is on anticoagulation, whether to go for a GA or a spinal, that is definitely a big concern. And the risk of bleeding or to weigh, it's whether the risk of thrombosis is high or the bleeding is high. That is definitely one point. Second is the patient has a history of MI. So monitoring, intra-op monitoring, going for an invasive line, 12-lead ECG, and to ensure at no point there is an additional stressor which can increase the myocardial oxygen demand, resulting in the increased chances of MI. Okay. Third is neurological. Since the patient has a stroke, you cannot afford to have hypotension at any point. Fourth is elderly. This was the point I was actually looking for. And that's why the question says it is an 81-year-old male. And when you talk about elderly, there are again 100 of points. Drug dosing, okay? Post-operative delirium, okay? Post-operative cognitive dysfunction. Which drugs, sedatives, hypnotics, better to be avoided? Okay? So next comes, I was asking you whether to go for the surgery immediately or it's urgent. You mentioned it's urgent, but you told 4 to 6 hours. The recommendation is you have to fix within 36 hours. Okay. Maximum 36 hours. If this patient would have been on rivaroxaban but not on clopidogrel, I would have wait for 12 hours to win off, if the RFT is normal, to win off the effect of rivaroxaban and then to go with the surgery. So the single question test your knowledge about rivaroxaban, about a clopidogrel, and if you're aware of the time duration and what is the acceptable reason for delaying surgery. So this is 2011 guideline, but recent 2020 study has come. Again, they have carried forward the same points what was there in 2011. So if there are few points, so like for me, point number 7 is a reversible coagulopathy. If the patient would have been on isolated rivaroxaban, I could have waited for 12 hours for the effect to wean off and then go for a surgery. Okay. Then I asked you about bridging therapy. So as you mentioned, the patient who is on warfarin, you can go for a IV low molecular weight heparin. But how do I decide? So here come the decision making between to evaluate between the thrombotic risk and the risk of bleeding. If you find the risk of thrombosis is high, then that is something like you have to take a risk benefit. And Edaic board is very happy taking a question on this risk assessment decision making. So there is something called as pre-thrombotic risk. So these are the patient, like as you mentioned, the patient on OC pills, that is a risk factor. That is not a high risk. So high risk patient, moderate and low risk. So the patient who is on mechanical heart valves, one of the candidate had written in the chat box about mitral valve prosthesis. That's the correct answer. And if it's an aortic valve, it is a caged valve or a tilting valve or a recent stroke or TI in less than 6 months. If the patient has arterial fibrillation, then you have to know about CHAD D2 scoring. And CHAD scoring is very, very important as well. Okay, so this is the CHAD scoring. So it has all these following points, and accordingly they have given the point. You should be aware of the full form of CHAD score and CHAD VAS2 score. Okay, and when you talk about bleeding, there is again one scoring system named as HASBLED. So if you see, this will tell you if the risk of bleeding is more or the, like you have to go for evaluation of both bleeding and thrombotic. Then you decide, take a call whether to continue with the bridging therapy. And if at all bridging therapy is needed, you have to first identify who are the at-risk patients. Okay, and for the rivaroxaban, as you have correctly mentioned, this was previous recommendation to start on 48 to 72 hours. The current recommendation, you can start immediately after surgery if the drain sites, whatever you answered was correct. Fine. Okay. So then coming to your reversing the, as you have correctly mentioned, dabigatran, it is not idalizumab. Idalizumab is a drug that is used for rheumatoid arthritis. It is idarusizumab. Okay. Then comes oral factor 10 inhibitors, rivaroxaban, that the dosing will depend, the adnexanet alpha, the dosing will be depending on whether it is less than 10 mg and the last dose if it is less than 8 hours. So the dose is different. You may not remember the dose, but you should be aware that the dose are different based on these two factors, the dose of rivaroxaban and when the patient had the last dosage. Second is factor 4 PCC. Okay, if this is not available, you can go for a factor 4 PCC. As you have mentioned, the 4 factors 2, 3, 2, 7, 9, 10. So these are the 4 factor PCC. So I have answered all of the question, I guess. So this all we discussed. What are the on arrival blocks? How do you clinically evaluate? What are the anesthetic consideration for the patient? The classification of anticoagulants, not just I put a question on direct anticoagulant, but they will ask you the overall anticoagulation. What is the bridging therapy? How do you risk for the thrombosis and the embolus and the bleeding risk? What is your plan of anesthesia? So I didn't answer this question. Since this patient is on clopidogrel, as I've correctly answered, so I will go for general anesthesia with the preferable analgesia, regional analgesia. Okay. Then what are the factors affecting the decision on GA versus spinal? This I've already answered. So you should talk about the coagulation profile, about if the reversal of the agent is available or not, and if at what was the last time that patient was on dosing, what was the dose the patient was on, and then the bleeding and your risk. Post-op pain management, again, I would say go for a systemic approach, non-pharmacological, pharmacological, and interventional. Non-pharmacological, reassurance, cold therapy, musiotherapy, hydrotherapy, all this. Pharmacological, go for a stepwise approach. Post-op patient, you should avoid giving NSAIDs as much as possible. And then comes to your interventional. Interventional, always, also you can talk about PCA morphine as you have mentioned. And in the interventional, you can always talk about the superficial plain blocks like fascia, iliaca, C5. Okay, they can put the same case as an elective case. The patient is going for a TKR surgery. The patient is on warfarin. When do you start? When do you stop? So there can be multiple questions on this. So you have to know about the latest ESRA 2022 guideline on RA and anticoagulation as well. Are you happy?
Yeah.
Okay. Thank you.
That was excellent. There was so much of learning, and I think you structured it so well with questions and backed it up. That's it. The final taste should be the best one. That's what I started it. It got better with Palbha. It got even better with Dikshita, and now the final taste will be the best.
So somebody has asked me about PCC4 and PCC3. Okay, so PCC4 has 4 inactive factor 2, 7, 9, 10, whereas the PCC3 is 2, 9, 10. It has no 7. Okay, and another is activated PCC. So it contains all the factors, and among them, only the factor 7 will be the most active form, and PCC is being asked in your exam. Yeah. No, Dr. Levings, don't beg. Don't worry. We will give you all articles. You don't have to beg for articles, right? Don't worry. We are very helping group, helping kind of people. So as such, we will give you like that only. So these are the few articles I will share with you guys. This is the Griffith study 2020 in an association of anesthetist. Okay. So this is the guideline for the hip fracture. This is from where I have quoted few things. Then I think, and other was from Up to Date. Okay. So Up to Date means it's you can find the chat to where we to score everywhere. Okay, who is coming for the next one? Please elaborate on Dr. San. I'm happy to host you. Okay, Dr. San, I have one option for you. You have to choose whether you want to go for regional with me, you wish to go with chronic pain with me, or you wish to go for ICU and some emergency with me.
Regional.
Regional. Okay. Regional. Are you sure with regional?
Yeah.
So because you should always, when the examiner give you an option, you should always go with the thing which you are more comfortable with, right?
Yeah.
So I give you the scenario here. Just give me a second. Yeah. So can you see my screen?
Yes.
Okay, now you could have a see. So you have a 35-year-old male who is a sports player and has rotator cuff injury and is now posted for shoulder arthroscopy. So you have exactly 1 minute from now.
Yes, ma'am, I'm ready.
Very
For
nice.
the questions.
Very good. I'm sure. Have you done regional anesthesia?
No.
Then choosing and getting ready so fast is it's really a surprising thing. Fine. So can you tell me what is the nerve supply of a shoulder joint?
Shoulder joint. It is supplied by. It is supplied by the branches of the brachial plexus. Actually, I'm not sure. I'm sorry.
Just try to like imagine the anatomy, how it goes, like brachial plexus. What are the nerves of the brachial plexus and which supply the shoulder? If you can remember something.
Yeah. So brachial plexus, it is formed by C5 to T1. So C5 to T1 roots, and then we have roots, trunks, divisions. Then cords, then branches.
Okay. And what are the nerves that comes in C5, C6, if you can remember?
So C5 and C6, they will form the upper trunk. So the anterior divisions, it will form the
Okay, no issue.
No issue. Yeah.
So, can you tell me what is your analgesia plan for this patient? Anesthesia plan for this patient?
So for shoulder arthroscopy, I would be giving interscalene block to this patient. Yeah.
Okay. So,
And
will
if
you-
required, I'll supplement it with general anesthesia. If the block is not adequate, I'll.
Okay. So this takes you to another question. So how do you decide whether to go for a GA or a interscalene block? Like, what is why I think probably you're thinking that your block will not be adequate. So if it is done in an expert hand, so definitely the block will be adequate. So if the block is adequate, can I go with interscalene or do I need a GA? If no, why? If yes, why?
So I think if the interscalene block is, if it is perfect, then we can do it in regional anesthesia. If we the position will be lateral position, so if the patient will be uncomfortable with that position, so it's better to give GA with interscalene block.
Okay, very nice. So can you see my screen now?
Yes, ma'am.
Yeah. So if you see my screen, can you, sorry, I got something. Can you see?
Yes, ma'am, I can see.
Yeah. So I will tell you, the aspect marker is on the medial side.
Yes, ma'am.
So this is structure number 1. This is structure number 2. And these 3 arrows are 3, 4, 5 from anterior to posterior, means from up to down.
Okay, yes.
Tell me what are the structures.
So structure number 1 is scalenus anterior, and scalenus medial, structure number 2, and this upper trunk, 3, 4 is middle trunk, and 3rd is lower trunk.
Would you like to reconsider your answer? Where do you exactly perform interscalene? At the level of trunk or the level of roots?
Oh, sorry, at the level of roots. Sorry. So there's a traffic signal sign basically. Which we
Yeah.
see.
Yeah, that is formed by?
C5, yeah. That is formed by that is formed by the roots actually.
Yeah, which roots? That is the question.
C5, C6, and C7. C8 is not there.
Okay. So according to you, the upper mark is C5, the lower is C6, C7, and the lowest one is C8. Is that what I understood? Because this looks like a traffic light.
Yes, ma'am.
Fine. So suppose this patient is a COPD, like he has history, is a smoker, and he has severe breathlessness. Okay.
Yes, ma'am.
So as you're aware that interscalene is associated with issues, respiratory issues. So what are your other RA options that are available?
No, actually, sorry, I cannot remember right now.
Okay, fine. So the surgeon preferred to perform the surgery in a beach chair position and 20 minutes after induction. Okay, I will share the screen again. Okay. So your surgeon, he decided to perform like in the beach chair position, and 20 minutes after the induction, the patient had sudden severe hypertension with bradycardia.
Yes, ma'am.
Yeah. So what actually went wrong? What are your differential? How do you manage?
Probably in a beach chair position, he may be having a venous air embolism. So first I'll call for help. So patient is having severe hypertension and bradycardia. So there is something wrong with the patient. So probably it is venous air embolism. So we'll follow the ABCDs. First we will call for help. Then look for the.
Expect is a venous air embolism. It's just 20 minutes after the surgery. It's just after the induction in 20 minutes. You observe the patient having severe hypertension with bradycardia.
It could be. So I've given a block to this patient. So there could be intraspinal spread in interscalene. It could be spinal spread. Yeah.
So what will happen if there is a spinal spread? Spinal or epidural, you mean?
Epidural, sorry. Epidural spread.
So what happens? Why if there is a epidural spread of the drug, why there is a hypotension and bradycardia? Are you aware of any reflex that is commonly happens in a patient who has epidural anesthesia? That is because I'm just asking if have you seen severe hypotension with bradycardia in a patient who has administered epidural?
No, ma'am.
Have you heard about basal-Charest reflex?
Yeah, it's a vasovagal reflex.
No, I'm asking not vasovagal. I'm asking
Okay, yes, basal gyrus, because of severe hypertension, low ventricular volume, there is bradycardia.
hypertension or hypotension?
Hypotension, less ventricular volume. Whenever there is lower ventricular volume, so the reflex is initiated and it will cause bradycardia. That is basal gyrus.
Okay, so how do you manage now?
We'll give vasopressors and atropine, basically. Injection atropine 0.6 mg. And fluids and vasopressors, basically.
Anything else?
I'm not able to answer.
Okay, fine. No issues. There is persistent bradycardia with atropine. What next?
So I'll isoprenalin, or if there is a hypertension, then we can go for pacing.
Very good. What pacing?
Venous pacing. I don't know. Sorry.
No
I'm
issues.
not prepared, actually. I'm just.
No, it's just this is also a tester exam. This is if you would have prepared, then why you would have come here? You would have given directly the exam, no?
Yeah.
It's just chilled out. Just try to assess yourself. So it's nothing to feel bad. Just try. That's all. Okay. What are your differential diagnosis apart from epidural spread of the drug?
Embolism.
Okay, good.
Then if there is if we are giving more of propofol, then also patient will have hypotension.
Drug error. Okay, fine.
The dosing, the volume which we have given in the regional block, that is more.
The toxicity, fine. Or any more?
Last.
Okay, that
local
is.
Yeah.
Okay. Suppose this patient has the monitors, because the patient is given GA. You see the monitor, your ventilatory parameters. It shows a very high rest pressures.
Okay.
The suspicion.
There is obstruction
Very
on the ET tube.
Very good.
That will cause high peak pressures. Or if there is spasm.
Very
then
good.
Also, yeah.
So you ruled out both. Rather, you found the air entry was a bit reduced. Would you like to do any POCUS intervention, point of care ultrasound, which can help you to manage better?
Yeah, in POCUS, we will see for pneumothorax or.
Okay. So, as you wanted to do a POCUS lung, so I present you the POCUS lung. Yeah. What is the finding?
Pneumothorax.
Are you sure?
Yeah.
Okay. So, to me, it is not a pneumothorax.
Okay.
Okay. You wish to continue, right? Or
Yes.
Oh.
No, I wish to continue.
So the POCUS lung shows normal, but there is a high suspicion of local anesthesia systemic toxicity.
Yes.
How do you manage?
So we will do for local anesthesia systemic toxicity. We will do ABC. We'll look for the airway, breathing, and circulation, and then the drug of choice which we are giving here is interlipid, 1.5 mg per kg. And if the CPR is needed, then that has to be continued for longer time. In
What
local
is the other modification in CPR in a patient of last?
That it has to be continued for at least 45 minutes.
That is one. And any other?
I think we should not give lignocaine.
Okay. Means you mean you should not give class 1 antiarrhythmic, if I'm right. This is what you mean.
Yes, yes.
Okay. Apart from that? Okay.
No, I'm not getting.
I know you will not get after this because you're already blocked. So this is what exactly the examiner does. You started very nicely. Somehow you missed anatomy, but somehow you recovered well. But the problem is, main problem, what I feel is, you all the people who are writing in chat box, I can see you all have tunnel vision. Okay. You feel I'm giving intestinal means I will talk about local anesthetic systemic toxicity. I was not talking that time about local anesthetic systemic toxicity. I was talking about epidural spread of the drug and basal gyrus only. And she somehow wanted it to push to venous air embolism. So every time embolism was running in her mind. So in exam, you have to have a wide vision rather than a tunnel vision. You should think in all perspective that is possible, not just one what you know or what you want the examiner to ask. Okay, it is not like your MD exam. So they have already the set of questions. They want to have a flow. You try to be flow with their flow. What happens? Because I mentioned it's a big chair position. I mentioned in interscalene block, there are equal chances of epidural spread of the trach. That can result in presoschialis reflex. And she correctly identified it. Then I wanted to give a scenario to confuse. It can be pneumothorax. Again, it rolled out by a POCUS. Then I brought the scenario of a last. If the examiner want to give the scenario of a last, he will definitely give you some ECG finding. Okay, rather than just telling hypotension and bradycardia. So this is one of the differential, no doubt, but don't jump into diagnosis. Rather, you can tell these are the likely diagnosis.
Okay.
Fine. So I take you to the question now. So as we have correctly, you have mentioned I'm sure you are very much confused with the anatomy. So the shoulder, the nerves supplying the shoulder are mainly the axillary and the suprascapular nerve. Other nerves that do supply are the subscapular nerve, the musculocutaneous sumbux right, lateral pectoral nerve. So the most important are this suprascapular nerve and the axillary nerve. Okay. So next I was asking her the anatomy. So whatever you told was right, but this part was grossly wrong. So this is anterior scalene, as she correctly mentioned. This is middle scalene. This is C5. Okay, the traffic light sign is not formed by C567. That is an old concept. The current understanding based on cadaveric study is the traffic light sign is formed by C5 and the bifid C6. So it is C5, the bifid C6 and down is C7. So interscalene is to block the C5 and the bifid C6. Somehow the drug trickles down and block the C7. And it's asking the imaging question, so you should be aware of it. Then beach chair position came. So when you're talking about bradycardia, you directly jump to atropine. You directly jumped. That is the mistake you do, and that is what the examiner want. You should do such mistake. Always you have to talk in a systematic manner. You have to stop all the stimulus. Check for the pulse. It can be electrical, means PE, pulseless electrical activity. If it is a pulseless electrical activity, you have to start CPR. If it is a bradycardia with severe hypotension, then you have to give atropine. Okay. Then you have to check on the A, oxygen delivery, hypoxia you have to rule out. You have to check for adequate breathing. You have to check for the circulation, the rhythm, perfusion, the blood pressure. Then D is the depth of anesthesia. Other drug, if there is atropine does not respond, as you correctly mentioned, is the adrenaline. Okay. Then you can have to go for a transcutaneous pacing because this is an emergency. If you have time, once you are done with the transcutaneous pacing, then you go for a transvenous pacing. You should not jump to a transvenous pacing right away. Okay. These are small things which you should know. So these are the differential diagnosis. Drug error you have mentioned, pneumothorax you can have to think of because it can cause tension pneumothorax if it's a positive pressure ventilation. I gave you a scenario of a COPD as well. Then these are the other likely diagnosis. Fine. So coming to the question, what kind of anesthesia? Definitely you have to go for a GA because shoulder arthroscopy takes at least 3 to 3.5 hours duration surgery. That is depend on the surgeon, but average is 2. So turning the patient in the beach chair on the lateral position for 2.5 hours, the shoulder, which is dependent part, is very painful and uncomfortable. That's why GA is better to be given with regional blocks. Okay. So you have to state. And second is they do a huge capsular distension with high pressure saline. That also is very painful, which is not taken care of by the interscalene. So that also causes a lot of discomfort. And posterior, the infraspinatus nerve to infraspinatus muscle, that also is at times spared. That is also a shoulder T-pain is at times that it's present. So in taking 2 scenarios, you can go for a GA with analgesia. Gold standard choice is your interscalene. However, if the patient is COPD, as one of the candidate has told about costoclav, it's one of the good answer, but he told about low volume. If you give a low volume, it will not go up to the root level to block it. So always you have to, if you're giving a costoclav, then you have to give a high volume costoclav. Other options available are, you can go for a selective truncal blocks, okay, where you specifically only block the C5, C6 upper trunk. Other options, you can go for a supraclavicular brachial plexus. However, it is also not free of no pneumothorax. It can cause pneumothorax. Since you are using for analgesia, the safest option is to go for a shoulder block. Shoulder block is a combination of the suprascapular nerve block and an axillary nerve block. Okay.
Okay.
Then next pneumothorax. Why I say it is a non-pneumothorax? Because you can see the entire pleura is moving uniformly. There is no stopping of any point where you can see the pleura is not moving. So if you think the patient died, so it's a raised intrathoracic pressure means you always think it will be a pneumothorax, not necessarily. It can be a mild tube kinking also. It can be a mild, any kind of obstruction. It can be a lower size of tube with which patient has been intubated with. So go with a systematic approach. Go for A, look for any tubing kinking. B for look for if the tube size is correct. As you mentioned, if there is a bronchospasm, then you go for a C, circulation. Okay. If there is a chances of any embolism or has happened for which there can be rest ICP. If there is any secretion clot, any migration has happened, any blockade of the tube. Okay, so always depth of anesthesia. If it is inadequate, then also there can be a rest ICP, not necessarily it will be a pneumothorax. So in Edaic exam, they look for the systemic way of your answering rather than just pointing out. We have a tendency to jump to the diagnosis and jump to the one of the most important management. This is not what Edaic exam is about. They want you to answer in a very systematic manner how you will do to a patient in real life scenarios. Okay, so don't jump. That is what was the main motto of giving you this example. So finally, it comes to last. However, the dosage you told were incorrect. It's a very important question. You should know the exact dosage of 20% intralipid and when to give how many boluses at what interval. You can give all these questions usually come. Then what are the difference in CPR guideline? One of the told you to is a prolonged time with the CPR has to be done. Apart from that, your dose of the adrenaline should be restricted to 1 mg per kg, unlike 1 mg that is given for a normal CPR, means last CPR. Other than that, you should avoid vasopressin and any drug that is class 1 antiarrhythmic. Also, because it is a non-reversible cause, you can go for a ECMO CPR, eCPR, that is being new. It's a new terminology. Okay, am I clear?
Okay. Yes.
Yeah.
Thank you, ma'am.
Okay, everyone
Fabulous.
will be selecting the places rather than listening to me.
Yeah, I think I have distracted people from your session by opening this up.
Yeah, I can see that.
No, I think it's important that before we leave, we give you something to think about. It's so important to look forward to the next meeting. So that's why I floated it in the background. All the things that you want, slides and everything will be available. Once you come face to face, there'll be so much material to share. There'll be so much information and guidance. It's not just information; it's a lot of guidance that you share face to face. People who attended our Bangalore last year February session, they just didn't know how to react with the amount of information that was thrown at them. They were like, we didn't expect that much in just 2 days. So it's really important that if we can do a face-to-face session, a face-to-face weekend course in India, probably. I think India is the hot favorite at the moment. And I'm sorry for people who are not from India. So there are candidates from Nigeria and people are based in UK. You have enough time to plan your holiday if you're Indian based, or even for people who are from Nigeria, they can always come in and enjoy the Indian hospitality in that period. But more importantly, it's so important that some of the face-to-face discussions are really add a lot of value to your preparation. So we'll have a discussion amongst the faculty. Probably by the end of February or March, we might run a face-to-face session, and we'd like to know your interest. We will run another session later on in the year as well, September and November, as you said. But we'll see what's the response to the first session, and we will take it from there. We'll bring some faculty from UK, and Dr. Amrita and Dr. Dikshita will be there as well. So we'll have a good, well-rounded sort of course to help you with the preparation. Sorry, Amrita, I interrupted you in between. It was.
Anyways, I think Dr. San, she was there at least with me. That is.
Yes, ma'am.
While you were sharing your slides, there was no response. People were listening to reading your slides. After the sharing of slides stopped, that's when I started getting the responses. So I couldn't distract them with while your slides were there.
That's so nice.
But you guys can unmute yourself. Let me just enable unmuting. It is what's your feedback for today's session? Any questions, anything that you want to ask? Just feel free to unmute yourself and share your experience from today.
Sir, I attended this for the first time, and it was a very good experience. Actually, an eye-opener, like the kind of approach that we should have while answering the questions, and how we should attend. I mean, what we should actually try to understand what the other person is actually wants to listen from us, or wants the exact answer. What we should have a broader approach. This is what I got, the main bottom line of the today's session. But it was a very good interactive session. Thank you.
That's great. That's great. So there are certain things which are very major and broad things that you learn from this course. There are lots of minor nuances which you can only pick up by repeated interaction with us. The broad thing to learn from today's session, I think, major thing is that if you think that by accumulating knowledge you will pass this exam, then you need to think of an alternative approach. That will not help you. Just knowledge enough is not the way to pass this exam. So there is a lot more in your preparation that you need to put in. One of them is approach, of course, how you present yourself, how you structure your answer. The other thing is your non-verbal communication. Non-verbal communication is how you sit in front of the exam. So if I'm giving a Viva and constantly I'm thinking or I'm looking that way and answering, there are a lot of people who do that. They answer and they look upwards and they don't interact with the examiner, or they are very stiff and all these things impact your Viva. You might think there are no marks for this. Yes, but your interaction with your examiner gets affected. Your own performance gets affected. So sounding relaxed, interacting with the examiner, it is as if it's a conversation. That will help you open up. That will help the examiner help you in delivering more points. So all those things are non-verbal skills that you learn by sort of facing us more repeatedly. With your Vivas, most people, I would say most experienced people who have not done exams for a good 4, 5 years or 10 years or so, there are two areas where they typically struggle. Most people struggle with basic sciences. You wouldn't have revised physics or pharmacology or physiology very recently, or if you had, probably just bits and pieces of it. Secondly, most people practice anesthesia and not intensive care. Very few people practice intensive care as well. So those are the two areas where you struggle most. Then the recently added components. So focus, all the image-based questions, lung ultrasound, FICE, FATE, all these things are recent, and a lot of people are not familiar with them. Thirdly, very sort of institutional-based questions, where when you are not practicing in an institution where you follow SOPs, then these questions you miss out on. Like, what is bridging therapy? A lot of people have not heard of bridging therapy. How do you manage a patient who's on anticoagulants with different indications? So you might start making up an answer, but there are very set protocols for that which you should be aware of. How do you manage glycemic control in a patient with major surgery? That again, there are set protocols for that which you can. So you can't make up things unless you have gone through these questions yourself. So these are the areas which will help you when you do these Vivas more regularly and face to face, and that is where you will you'll be able to eliminate all the gaps in your knowledge. You have to focus on the gaps in your knowledge. You can't focus on your strengths. Strengths will always be there. Even after 10 years, those topics will still be fresh in your mind. But the gaps will widen, and you fall into those gaps in the Viva. So make sure your knowledge gaps are well filled up. So I think that is the main aspect. We are going to start something called as topic-based Vivas, which are 10 weeks Viva, which I discussed earlier. This is the Viva which I especially recommend that you guys take. It is 10 weeks of very structured work. You know exactly what you're going to be facing the coming weekend. Read as much as you can. If you don't get a chance to read everything, you will still be able to say something and learn a lot in that session. So that is what I would suggest would be your go-to Viva next if you can't attend the face-to-face courses. I think I've done my bit of talking. I will pass on to Dr. Amrita for her.
Dr. Livings I have not seen. I just saw him in Dikshita Viva, but his comment was, I think, one of the best comments.
Well, I beg you.
No, sir. This session was like honey for my ears and silk for my brain.
Oh,
I'm sure.
Ma'am, can I say something right now?
Sure. You can switch to video as well. We can also see who is that poet with us in academic now.
Yeah, I mean, I wanted to see you in the Viva itself.
Yeah, I'm actually doing a fellowship in trauma. So the articles you shared for me was really eye-opening.
Which place?
Sorry?
From which place?
I'm in MIOT in Chennai, Madras Institute of Orthopedics and Trauma.
Oh, nice.
So the articles you said about hip surgery and this anticoagulation, right? It's really eye-opening. I'm planning to go through it thoroughly. I'm really glad I joined for this session, ma'am. Thank you. Even Dikshita, ma'am, really, you humbled me a lot. Thank you for that beautiful session. I'll really put in the effort now to improve myself.
I'm sure you're having a lot of experience in MIOT because I'm from Chennai as well.
Oh,
so,
wow.
Yeah. So, I mean, yes, definitely you can. I mean, we will share a lot of articles of, the latest articles, which will really help you in your daily practice as well for these exams as well. But overall, it's the structure and how you have to answer which really matters. And of course, and more of a practical approach rather than going into, just answering factually. How would you answer in that? I mean, how would you deal that particular situation when you're facing it? That is more important. What are you things you're going to anticipate? That really shows that, okay, you have gone through this. And even if you've not gone through, you should have to show to the examiner that you've already gone through it.
Yes, no, that makes sense. That definitely makes sense.
Yeah, you should not jump into something. Like I know when you ask about malignant hypothermia, I've seen the first Viva, no, they directly jump into dantrolene.
Yeah.
It's not what the Edaic examiners it is not what you do in your practice, right? Arranging and preparing dantrolene will take at least 5 to 7 minutes in expert hand. So before that, you will do something, right?
Ma'am, I have a question if you are ready, okay to take one. So, ma'am, I've cleared my part 1 in September, and I had taken the last session before the exam, which in which you and Dr. Dikshita had given the slides and the quick prep one. So it had really helped me a lot. So thank you for that. And now I'm starting to prepare for part 2. So my main concern was that, Sir clearly said, ICU is something it's not easy to prepare. So would you just have some books or some places from where we can prepare for ICU? The other topics are easier to prepare from other resources, but for ICU, from where to prepare is also something I'm stuck at.
Okay. So for that, I will tell you, if I tell you a book, again, I will show you one thing. So if I tell you to go through a particular book, what will happen? No, you will be answering Berlin definition of, so you will be answering, can you see my slide, everyone?
Yes, ma'am.
If I ask you to go through Washington Manual or that Paul Marino, you are going to definitely answer the Berlin definition of ARDS. And now in 2023, there has an update on new global definition of ARDS. It is no more the Berlin definition. They are going to ask you the new global definition of ARDS.
Okay.
Okay. So there are few things for which you can go through Paul Marino and your, what is that, the book, Washington Manual. Okay. But at the same time, there has been a lot of updates. See, hypokalemia, hyponatremia, hypomagnesemia, hypocalcemia will not change. Sepsis, ARDS, this will change with time. DKA will not change. Pulmonary embolism will change with time.
Okay, I think then we request Sir to have at least a session on ICU and chronic pain, because that is something what routinely I am not practicing, so I'm not very confident in that.
Yeah, to add to the thing, as Dr. Amrita mentioned regarding the changing topics, I would insist you could, if you all can go through the latest updates, like, probably in the up to date, if you have the access for it, or you can actually use, I mean, to make a fast revision, you can do the Life in the Fast Lane, Litfil website. It gives a brief review of what's happening. I mean, what are the latest updates as well. So Litfil, LITFL, Life in the Fast Lane. So this can also give you an initial overview, but any day, at least the important topics, if you can have the latest articles and go through it, that will be the best way of reading. Because any one particular book is not going to be, as she rightly mentioned, the algorithm correction of hyponatremia, hyponatremia, all this is not going to vary. But what is going to vary is the topics like ARDS, septic shock and all.
Okay. So I'll try to do both. Okay. Thanks so much again, both of you, because those slides were actually the ones which helped me, before the exam for the quick revision. I had, downloaded your slides for the exam, just going before the exam. And they were really, really helpful. Like quite a lot of chunk was from that. So
thank you so much.
Thank you so much. Yeah.
Thank you. I mean, we are more than happy if we get such feedbacks from our candidates, which has really helped them.
Yeah, no. It was really beneficial. The last 1 week, it was very helpful. Thank you.
Okay, I'll just answer one quick question. There's a question on how to start preparing for Edaic Part 2. I think very important question. Where do you start? How do you plan? Although everybody's different, but I would give you one sort of way of making a more systematic start. Most important thing is, don't rely on going cover to cover on a book and then thinking I've done that. Instead, make a list of topics. There are topics which are more frequently asked. So make a list of an exhaustive list of topics, as exhaustive as you can. And if you're finding that difficult, then go to this website. This is FRCA Mind Maps. It is, just let me open it up. Can you see this? Can you guys see this? Are you guys able to see the screen that I've shared?
Yes, sir.
Okay. So this is FRCA mind maps. It's called mind maps for FRCA. Just enter into this website from here. It has lots and lots of topics. For example, there are things related to primary FRCA, all the basic sciences. They're all here. There are ITU topics which are here. Different guidelines, pediatrics, obstetrics, airway-related, cardiothoracic, miscellaneous, neuro, theater management, pain, regional equipment. They're not the latest articles. They are very outdated. Most of them haven't been revised for the last 10 years or so. But the objective is not to get the latest information. The objective is to get a scale of what you're dealing with. You scale the size of your problem. You make a list of topics. They may not be comprehensive, but at least you'll get a guide. So that you can take these articles. I mean, you can read from here as well. For example, epilepsy. So if you open up one of these windows, it'll tell you basically basic things about epilepsy. What are the causes of epilepsy? What is status epilepticus? How do you treat it? What are the considerations, surgeries for epilepsy, complications related to an epileptic fit, and the article that is associated with it. It has an article associated with it as well. So decent resource, but a bit outdated, but it gives you some idea of how to do the job systematically. So make up a list of topics that you need to cover so you don't miss out on very important things, and then try and read as much as you can around it, not necessarily from one book. Wherever you get the resource from articles, from different other reference books, but build yourself on around a particular topic. And when you have finished, let's say about 10 topics, and you are going to start the next 10 topics, before that, go back and open up, just think about one particular topic, like for example, epilepsy. Try and recall how much you can remember from what you've read. If you think that you remember 80% of the stuff, just put a green tick mark, which is very rare. But if you do remember that much, then put a green tick mark. If you can't remember more than 50%, put an orange, like a traffic light sign, orange tick marks or orange circle around it, around that topic. If you can't remember anything more than 25%, put a red tick mark. That's really important to revise that topic again. That way, you know exactly which are the topics you need to rebrush to get them highlighted. Those that are green, you don't need to touch them for some time. Those that are orange, come back after 2-3 weeks or after you've done one cycle of another 10 topics and revisit them. But the red ones you need to address immediately. Go back and fill up where you lack in those topics. And that way, if you cover 10 topics at a time and move forward, what you wouldn't have to worry near the exam is, where do your traffic lights stand? Are they all green? Are they all orange? Or are they all red? Most candidates closer to the exam think, I can't recall a word of what I've read. It's very difficult to recall. With these traffic lights, not just that you're subjectively feeling good, but you have evidence that your traffic lights are mostly green and orange. You haven't left any red traffic light. And that is a very reassuring feeling before the exam. So I would specifically say that it's called retrospective study or something like that, retrospective revision or something. But it's a very scientific way of following up in a systematic way. Reading books cover to cover, I assure you, people have done it before. For these exams, it is maybe 50%, 60% useful. But this technique will be way, way more useful for you. Okay? Any questions before we wind up? It's been a long day for you guys, and so it has been for the faculty as well. So before we wind up, any pearls of wisdom from you guys? Anything that you want to offer to us as a feedback? Okay, I think that with that we will finish today's session. Yeah, I hope you guys have a wonderful weekend of what's left of it, and we will hope to see you back again. Bye-bye and take care.